Certainly, at the private practices that I work at, we use gadolinium for our small joints, so our wrist and hand inflammation protocols. But you don't really need them for larger joints, so in the shoulder or knees or hips, because you can usually see the synovial thickening quite easily. For axial spondyloarthropathy, it's very similar. We're focusing on sites of where inflammation may be occurring, and typically this is the entheses or at the synovial joints. So looking at the ligament attachments on the vertebral bodies, but also the interspinous and supraspinous ligaments, the facet joints, and then the rib joints, looking for signs of edema as well as the structural changes. And again, we're using combinations of T1 and fat-suppressed T2 sequences. For the SI joints, we typically do smaller field of view, again, looking for active versus chronic inflammatory changes, and there's limited role for contrast. So let's go back to sort of the clinical diagnosis. Well, in the 80s, there were a number of criteria that were developed by rheumatologists, particularly out of the United States, that developed, say, the modified New York criteria for ankylosing spondylitis, as well as the rheumatological criteria for rheumatoid arthritis. And they had radiography as an important early criterion, but usually when you looked at those radiographs, it was often quite extensive or late findings. There's been a real shift in the last few years to have an earlier diagnosis because by identifying people with early disease, you can implement treatments that have that can really prevent advanced disease even developing. And because of that, it's led to a significant change in the criteria of many of these diagnoses. So going back to our list, let's go through the first one, the rheumatoid arthritis. So rheumatoid arthritis is a chronic autoimmune inflammatory disease. It affects both joints and extra-articular locations. It's more common in females, usually in the sort of later 4th to 5th decades of life. It's an unknown etiology, but it's thought to be multifactorial. It's associated with the HLA genes, and there is sort of a autobody response by T cells to synovial line structures, which is why it's often involving the ligaments or capsules of the joints, and then also tendons and entheses. It's typically a symmetric polyarthropathy, and in the hands and the feet where we often do the radiographs, it's usually a proximal distribution. So in the hands, radiocarpal, intercarpal and MCP joints, with usually sparing of the DIP joints. Classically, the erosions are at the margins, and you can, as we go back to the original sort of cartoon diagrams, that's occurring where you get the bare areas where the bulky pannus and synovitis is rubbing up against that bare area of bone, causing the erosion. And these are also quite prone to subluxation because of the ligament and tendon disruptions associated with the joints. You get deformities, so classically Z deformities or swan neck deformities. So this is a pretty classic exam case of rheumatoid arthritis. We have a proximal distribution, so involving the radiocarpal, the midcarpal row, MCP, and also the PIP joints. And we see that there is quite a lot of erosions as well as subluxation. And just to zoom up there, you can see these erosions here at the joint surfaces, particularly quite a lot of changes around the ulnar styloid, which is often prone because of the amount of ligaments that are attaching to that and the large surface area that it's prone to the bulky synovitis. And then we have the subluxation across the MCP joints. So this was a case of a young patient who came in for query, I think TFCC injury, and we can see that she's got a bulky synovitis across her carpus, so radiocarpal, her distal radioulnar joint, pre-ulnar styloid recess, and across the intercarpal row. And we can see that the joint effusion is not just a sort of bland effusion, it's got this sort of low grey level signal within it. And we can also see that there is quite a bulky tenosynovitis of one of her extensor compartment tendon groups. And Interestingly, if you look at her radiograph, she has almost no disease. So she's got no erosions. Her joint alignment looks completely almost normal. So the diagnosis in this case was purely based upon the MR. She went on to have sort of clinical testing, was found to be rheumatoid factor positive, and has since been started on treatment. So the imaging in this case is identifying early subclinical disease before it's even present on radiograph. Whereas in this case, this is an example of advanced disease. We can see there's a slack deformity of the scapholunate collapse, and there's ligament disruptions with erosions and deformity to the carpus. And in this case, this patient had no rheumatoid arthritis, but was being followed up with MR to look for sites of residual active disease while they were on treatment. So we can see that there is quite a lot of bone marrow edema at the distal radial ulnar joint and a synovitis. And we can see here that the lunate is completely displaced out volarly from the slack deformity. We can get it in the feet. So here is a case of multiple erosions affecting the metatarsal heads with areas of active inflammation, such as in the third MCP joint here, MTP joint, sorry. And this is a large rheumatoid nodule, which you can get at sites of sort of friction that are forming, so particularly on the hands or the feet. And another case of rheumatoid arthritis, again affecting the feet, multiple erosions in proximal distribution, and with inflammation, bone marrow edema, and here's a large rheumatoid nodule at the plantar aspect of the foot. So to go back, the 1987 ACR classification criteria for rheumatoid arthritis, you had to have more than 4 criteria to meet a diagnosis, and radiological changes were part of that criterion. So you had to have clear evidence of disease involving radiographs of the hand and wrist with a sort of equivocal bony decalcification, but it needed to show evidence of erosions. But this has since changed in 2010. The current classification criteria, even though it's about 14 years old, it still has essentially removed imaging as part of criteria for diagnosis, and it's almost exclusively based upon a clinical classification. So the distribution of joint involvement, do they have serological positivity? Short have the symptoms been present is in cases that might be slightly uncertain or it's just not really 100% clear exactly what's going on. So you might need to do an ultrasound or MR in order to clarify. And so the rheumatologists, they use these algorithm trees to help work out whether the patients are positive for rheumatoid arthritis, which you can see there. It just depends upon the duration and the serology. So moving on to osteoarthritis, this is an extremely common condition. It has both the strong primary genetic component, so patients that have osteoarthritis in families, it tends to run, but it can also occur in secondary osteoarthritis, so post-trauma or abnormal mechanical forces. So has there been previous injury to the joint, or is there excessive weight through that joint? So, for example, in obese patients. And it's typically a non-inflammatory arthritis due to cartilage loss that leads to the progressive destruction of the joint. So there is usually an asymmetric distribution, but the weight-bearing joints are often affected, so the hips and the knees, as well as throughout the spine and the facet joints. And then in the hands, it's more of a distal distribution, so DIP and PIP joints, as well as the thumb CMC joint. And as we sort of learned in, I think even in medical school, the classic radiographic changes are the sort of 4 pillars of asymmetric joint space narrowing, osteophyte formation, subchondral cysts, and malalignment. And I wanted to kind of go back to the beginning where we talked about how osteoarthritis is a productive arthropathy. And really it's because it makes bone in response to altered stresses that are placed through the bone because the cartilage has been removed. And so if you have an example of stress loading through the joint, you can see how you can make extra bone because you're trying to buttress the increased load across. And that gives you an example of how you get the osteophyte formation. This is a sort of classic case of a patient who has at least moderate OA in the knee. And we have some joint space narrowing at the lateral compartment with osteophytes forming, subchondral cysts, and some subchondral sclerosis. Compared to this patient who has severe osteoarthrosis, where they've essentially got bone on bone, the medial compartments with a marked genu valgus deformity. This is a case of a patient who has peripheral distribution affecting the DIP joints, and it's prominently osteophyte formation with joint space narrowing, which is a sort of a classic case of osteoarthritis. There's relative sparing of the radiocarpal and proximal carpal row, and maybe a little bit of changes involving the CMC joint. As opposed to this case, which is severe osteoarthrosis at the first CMC joint with joint space narrowing and osteophytes. And then this is an asymmetric process. Worse at the right hip, there's complete disruption of the joint, cystic changes, and sclerosis with osteophyte formation. So in this case, you wonder whether there has been a secondary event. Has there been prior trauma, like an insufficiency or fracture or avascular necrosis, or is it purely just related to chronic asymmetric cartilage wear? Now, there's a subgroup of osteoarthritis called erosive osteoarthritis, and this is kind of important to mention in an inflammatory arthropathy session because it's the one that mimics inflammatory arthritides. And I find when we go to our rheumatology meetings on Fridays, and the rheumatologists are always bringing cases where they want to know whether this is, active or erosive osteoarthritis, or does this person have an inflammatory arthropathy? And you usually have to kind of look for the secondary changes of osteoarthritis. So we're looking for the joint space narrowing and the osteophytes. But with erosive, you can get erosion centrally, and it gives you this classic gull wing appearance. And I'll show you some examples in a few slides. And the other thing that happens is that because you get so much joint destruction, that you can get horizontal subluxation of the joints. This is compared to rheumatoid arthritis, which is often a vertical subluxation. So here's these gull wing osteophytes, and if you overlay the gull wing, you can kind of see that real undulated appearance of the subchondral plate and the slight widening that can happen from the erosions. And so here is some examples further of gull wing osteophytes and joint space narrowing and that subtle horizontal subluxations that are occurring. And in this case, we can see that there's also disease involving the thumb CMC joint. So the pattern fits more with an osteoarthritis and potentially with erosive change. Now, this is an MRI on a patient who has active erosive osteoarthrosis. So it's predominantly involving the DIP joint, but in this case, it's also affecting the index finger MCP joint. So there's bone marrow edema with a synovitis and a small effusion, and which is the actively inflamed joint, but the DIP joints that I've shown in these pictures are less inflamed, but it would suggest more of an erosive arthropathy rather than erosive OA rather than a rheumatoid. Now, moving on to psoriatic arthritis is an inflammatory arthropathy, which is a seronegative, so it's rheumatoid factor negative, and it's usually associated with HLA-B27 positivity. There's no gender predilection, but it's frequently associated with extraskeletal manifestations, so the skin, as well as GI and GU problems, and as well as ocular abnormalities like uveitis. There's different subtypes depending upon the distribution, which I won't go super in detail, but you can get just spondyloarthropathy involving psoriatic arthritis, or it could be more of a peripheral distribution. But alluding back to the beginning, psoriatic arthritis is one of those conditions where it has both erosive and productive changes. So the erosions are typically marginal, and the productive gives you this periostitis. So the location when we're looking at psoriatic arthropathy is going to be peripherally. It's going to be the DIP and the PIP joints, and it can also affect the axial spines or the sacroiliac joints, as well as throughout the vertebral bodies, etc. And then you get some classic radiographic findings, which you're really going to try and hunt for on your radiographs. So is there features of like a dactylitis? Is there periostitis? and then the sort of more advanced changes, which usually implies that, that the pathology has been there a while, such as the telescoping deformity of a pencil and cup of a arthritis mutilans. Now, just to highlight here, the classification criteria for psoriatic arthritis was updated in 2006, and you need to meet 3 out of 5 criteria. And radiology just with radiographs showing extra-articular bone formation can be one of those criteria, but you can meet the criteria without any imaging at all. So this is some examples of marginal erosion with the periostitis, and then there is also some soft tissue swelling of the digit, which would be enough to potentially give this patient a diagnosis of psoriatic arthritis. This is a case of dactylitis. This is obvious. The finger is grossly swollen compared to the middle finger, and you've got joint destructions with erosions affecting a distal digit. But, sometimes it can be more subtle, such as in this case of slight swelling of the second toe. So really, when we're looking at radiographs and there is a history potentially of a swollen joint, you really should be looking subtly for the subtle soft tissue changes. So here you can see that. Again, this is another case of psoriatic where you've got these subtle marginal erosions occurring, but with the periostitis, so it's pointing you more into a direction of it being a mixed arthropathy, potentially a psoriatic. And here's the pencil and cup deformity forming that arthritis mutilans, and eventually it can cause quite significant destruction of the joint and this sort of telescoping. So clinically, they can actually pull the finger out. And just another example. Now for MRI, again, we're looking for signs of active inflammation. So is there areas of bone marrow edema pattern, joint effusion, and can we see signs of erosion? In this case, they had some terminal tuft resorption as well as some bone edema of osteitis. So the MRI is really not used for the diagnosis, but it's used to identify sites of active disease. Here are some examples of paravertebral ossification, where you get that fluffy appearance along the anterior longitudinal ligament attachments. So going into ankylosing spondylitis. So this is a seronegative arthropathy, the same as psoriatic, but it typically affects the spine, and it's associated with HLA-B27. It can also affect like the sternoclavicular and hip and shoulder joints, but to a slightly lesser extent. It's usually a symmetric and bilateral process, and previously the New York grading criteria has been used for diagnosis. And we'll go through some of the sort of classic features of these osteitis and ossification and syndesmophyte changes. So these are the sort of classic appearance of syndesmophytes, where you get ankylosis of the vertebral ligaments, and it gives you this bamboo-like appearance to the bone. And it can get so severe that you get complete ankylosis of all the vertebral bodies. And in this case, we have complete ankylosis at the sacroiliac joints. And we call this dagger sign, where you get AP of the lumbar spine, and you can see that there's ossification of the supraspinous ligaments. These patients are highly susceptible to getting quite significant fractures of their spine. So this is a chalk stick fracture, so 3-column fracture, and potentially leading to catastrophic injury to the spinal cord, and in some cases has led to patients being quadriplegic. So here on X-ray, just to kind of point out another examples of this osteitis, or these kind of shiny corners on X-ray, where you get this slight increased bone density at the vertebral corners, and then a syndesmophyte forming. So there's a vertical strut that's occurring at the ligamentous attachments, as opposed to ossifite, which tends to grow outwards because of the increased load placed upon the vertebral body. So in 1984, there was the modified New York criteria for ankylosing spondylitis, and radiography played a really important role in the diagnosis of these patients. So you had to have clinical features like lower back pain, and had to be for greater than 3 months, and with but not relieved by rest. And the radiology was important, so you had different gradings of the sacroiliitis in order to meet it, and we'll go through that. So here are some examples of varying grades from 0, where there's normal findings, to grade 4, where you have complete ankylosis. Now, most of the time, the challenge is between the grade 1 and grade 3, where you have areas of subtle or suspicious changes or some sclerosis forming. So how do you sort of define these? Well, the moderate is kind of, once you sort of work your way backwards. So moderate is, there's established disease, it's on both sides, and you've got erosions, and you may even have partial ankylosis. The joints may be widened, but clearly it's sort of abnormal. Grade 2, you have some areas of, definitely looks like there's some disease. You have erosions and sclerosis, but it's not as sort of severe as grade 3. You don't have the joint space widening, and you don't have any extensive ankylosis. And grade 1, I find quite challenging sometimes comparing it between a degenerative change, where sometimes you get a bit of sclerosis that forms, or it can overlap the changes. But really, you're looking for signs of blurring of the subchondral plate or subtle areas of erosion. But really, in Australia, in order for our patients to meet for PBS criteria for certain medications, they need to have either a bilateral grade 2 diagnosis or a single side of unilateral grade 3. But really, what has changed in the world of seronegative spondyloarthropathies is that there has been sort of a progressive shift to now moving towards this axial spondyloarthropathy diagnosis, versus a peripheral spondyloarthropathy, rather than the older classification system where we define them either being angstspond or psoriatic or IBD or reactive. So there's a general push towards defining it based upon is it just involving the spine or the peripheries. And that's led to the society, the ASAS Society, developing an updated criteria for imaging for diagnosis of spondyloarthropathy in 2009, and that had a reduced role of imaging diagnosis. So you can meet the criteria based upon clinical findings, but you can also meet it on sacroiliitis on imaging, and that could be from both X-rays and MR. And the consensus by the group is that if you are going to do MR, one of the sort of key features in the spine is looking for those inflammatory changes at the vertebral corners. So it usually indicates quite high specificity of disease. So in patients under 40 years of age, if you see these shiny corners or inflammatory lesions, it has a specificity of about 97%. So here are some examples of those inflammatory changes. So we have some areas of bone marrow edema pattern forming in the vertebral corners. And we have some here, this is a T1 where we have some areas of fat that started to form at that area. So you're starting to get some changing or marrow metaplasia at sites of inflammation. We can see sites of syndesmophytes starting to form as well, such as here. And then we're looking for signs of inflammation that are occurring in the spinous processes of enthesitis. You can also get these Anderson lesions where they almost look like a spondylodiscitis associated with a disc or a Schmall's node, and you get a vertebral body inflammation occurring around that. So in this case here, we can see that there is some subtle areas of bone marrow edema forming at the corners, and we're looking for the subtle structural changes. So here is some fat marrow metaplasia or backfill forming, and looking at these inflammation at the spinous processes. So this is a patient who had diagnosed with axial spondyloarthropathy. So just to point out, if my arrow didn't show, there are some areas of active inflammation. Now, when we're looking at SI joints, really radiographs still remain a first line for diagnosis, but if they're normal, then you might want to consider doing MR. But also in patients that are young, you might want to consider doing MRI, because sometimes it can be challenging to identify structural changes, particularly in sort of pediatric patients, or if there's only a short symptom of duration in which you're trying to pick up on those active inflammation. So in the SI joints, again, we're looking for areas of periarticular bone marrow edema. So is it occurring up adjacent to the subchondral plate? And sometimes it can be subtle. You have to window your images, and you can take, you need to sort of go over a number of slices, and you're looking also for signs of erosions at the articular surface and joint effusion or periarticular edema. Now, the chronic structural changes include sclerosis of the subchondral plate, as well as erosions, fat deposition that's occurred up to the subchondral plate, indicating that there's been backfill, as well as ankylosis. So they're all chronic structural changes. So here's an example of a patient who has bilateral sacroiliitis. And we can see on this T1 that there's all these areas of marrow that's extended up to the subchondral plate. So this is an example of backfill or fat marrow metaplasia. So this has occurred at a site of old inflammation. And we have almost ankylosis across the joint at the inferior margins, but there are still some areas of bone marrow edema pattern at the superior aspects of the joint with subchondral sclerosis. So there's active disease. It's mainly at the superior joint margins with evidence of chronic disease and ankylosis at the inferior joint margins. So this patient had grade 3 sacroiliitis. This is a different patient, and we can see here that there's bilateral abnormality. We can see blurring and indistinctness of the subchondral plate, more on the iliac sides bilaterally. We can see areas of potential erosions that are forming. So in this case, I would probably give this a grade 3 diagnosis. And this was the MRI, where we can see that there is areas of, again, fat marrow metaplasia, areas of subchondral sclerosis, and we can see that there is still a small area of active inflammation of bone marrow edema, so acute on chronic changes in this case, also with bilateral grade 3. So just to kind of emphasize here, what happens if you just have a peripheral spondyloarthropathy? So this probably encompasses those patients that would previously have been diagnosed as a reactive arthropathy. And so they may only present with peripheral symptoms with both they might have a single joint involved with active inflammation, but sometimes they might just also have sacroiliitis on imaging, but without the spinal involvement. So they have a sort of sub-classification system for these patients, in which case it's mainly based on clinical findings as well as potentially sacroiliitis findings. So what does this mean in terms of updates? Well, probably if we look back at all of our old ankylosing spondylitis cases, that all now be classified as an axial spondyloarthropathy. And most of our reactive arthritis cases would be classified as a peripheral spondyloarthropathy. But really, I think the emphasis now is to try and diagnose these patients early. So there is that window of opportunity to try and implement treatment early on so that you don't get a severe disease. And so there, with that move in that, there's a decreased reliance on imaging for that initial diagnosis, but the imaging remains important for disease monitoring. So moving now on to some of, lastly, in the last sort of next of the talk, just going to focus on some of the crystalline arthropathies because of the fact that it can mimic active inflammation. So gout arthritis is from sodium urate crystal deposition in joints. And here is a photograph of the needle-shaped negatively birefringent gout crystals, which you look for when you do a joint aspiration. Now, gout arthritis, it gives you damage to the joint because you get progressive flares of the joint, and it over time can manifest as tophi, and the tophi can be quite destructive to the joint. Now, I wanted to highlight as well is that gout deposition and concentration in the blood does not necessarily mean that you get acute gout arthritis. Usually it's a rapid change in the concentration of the urate crystals that precipitates an attack. So it can often be associated with starting a new medication, a patient is dehydrated, or they've had a recent sickness or a recent trauma to a joint, and that can be the thing that causes the active inflammation. So clinically, you get these swollen fingers, bulky and lobulated from the tophaceous changes, and it's typically seen in small joints. So the first MTP joint of the great toe is the most common joint that's affected, but we see it frequently in the hands as well. And again, the classic sort of radiological features are looking for those changes of tophi. Now, these tophi eventually form at juxta-articular areas, and they can progressively lead to erosions of the bone, and it gives you these overhanging edges. And with all the inflammation, you can get quite a lot of soft tissue edema and pannus. So my registrars love to talk about the rat bite morphology of juxta-articular erosion, and when you superimpose that onto your radiographs, you really can kind of get the idea that potentially this tophus has taken a big bite out of the side of the bone, and you've still got a residual rim of overhanging osteophyte formation. This is an example of a patient who's got, classic great toe gout arthropathy, but, subtle radiographic changes. You've got this erosion here at the juxta-articular surface. Is it really erosion, or is it an enthesopathic cyst that's forming at the subchondral, at the ligament attachments? And you've got this soft tissue density at the medial aspect of the joint, subtle areas of mineralization that are occurring, and no sort of erosions at the articular surface. But this patient went on to have a needle aspirate and was found to have the urate crystals, so was diagnosed with a acute inflammation of gout. And again, this is a more advanced case of that soft tissue mineralization and density with these rat bite-like erosions with overhanging joint margins. And there is complete destruction of these joints here, and this is presumably from gout as well. Now, we get occasionally MRs for gout arthropathy, and sometimes it can mimic soft tissue tumors, and you can sort of see why you get this large areas of tophus that form. And in this case, it's more obvious because it's centered on the joint, but sometimes it can just deposit in soft tissues adjacent to a joint. And you sort of have to kind of have that in the back of your mind when you're dealing with it. But here you can see these large erosions that are forming around a joint. So the diagnosis is pretty easy on MR on this case. What has really paved the way for gout, though, is the development of the dual energy CT, which you can do different spectroscopy, and in this case, it's for showing up the urate crystals. And in this case, this patient had extensive gout deposition, which you can see quite easily on the non-colored imaging, where there is this soft tissue mineralization forming around the joints and near the sort of capsular attachments with erosions, but it really labels up quite nicely on the dual energy with the green color formation in this case. And then this is another case of gout that's formed in the wrist, and this has been labeled red in this case. Now, the other crystal deposition to mention is CPPD, and this is one of those ones that often occurs with other arthropathies. So you could have OA with active inflammation because you've got a superimposed CPPD deposition, or over time you can get a sort of pseudo gout forming, and it gives you active inflammation or active arthritis, and eventually can lead to chronic arthropathy and joint destruction. So typically you can see the chondrocalcinosis forming at sites of menisci or TFCC, such as in the hands and in the knee. But you can also get the CPPD forming around the dens, like in the Crown-Dens syndrome. And as I said, you can get progressive destruction of the joint. So classically in the wrist, you can lead to a slack deformity. So here's a case of chondrocalcinosis in the knee. It may or may not be causing active inflammation in this case. Again, chondrocalcinosis in the TFCC without disruption of the carpal row alignment, compared to this case where you have slight widening of the scapholunate interval. And so the question of whether the CPPD is causing destruction and carpal instability should be raised. In this case, this person has, severe osteoarthrosis. They've got those large osteophytes, joint space narrowing, subchondral sclerosis, but there's just quite a lot of soft tissue changes in the joint space, reactive synovitis. And if you look closely on the middle image on the sagittal that there's quite a lot of low signal change and deposition in the joint and in the capsule. So is there some sort of crystal deposition that's involved? And I think in this case, they went on to have a shoulder aspiration and they found the CPBD crystals. So a superimposed CPBD arthritis in the setting of underlying osteoarthritis is extremely common. In this case, we have extensive CPBD deposition, all these low signal deposition in the ligaments, and we can see the erosions and active inflammation. Eventually, this would probably lead to carpal instability and a slack deformity unless treated. So just to kind of go back to the beginning, where can we help? Well, we can help to identify correctly what type of arthrosis we're dealing with. Are we dealing with a rheumatoid arthritis that has a classic pattern, or are we dealing with something, where there's no necessarily radiographic changes, in which case you might need to do MRI or a targeted ultrasound? And that can be helpful when we're looking for borderline or difficult cases. And the other sites where we can help are in cases of known disease, looking for active inflammation. So in a patient who has known active spondyloarthropathy or sacroiliitis or inflammatory arthropathy, which joints are particularly involved versus is there underlying advanced arthrosis of secondary OA. And we can also help to grade our sacroiliitis so that our rheumatologists can access medications easier for their patients. So hopefully in this talk, we went over some of the common arthritides with you and just highlighted, the key kind of radiographic changes, as well as some of the MR changes of looking for early signs of inflammation. Unfortunately, I don't have very many ultrasound cases to share with you, but, in a future talk, I'll have more saved up in my bank. But really, ultrasound and MR can be used synonymously in peripheral joints, but MR is pretty much the mainstay for spine imaging. And I showed you that there are the classification criteria for the main inflammatory arthroses have less dependence on imaging for diagnosis, but really we can still play a role, and our role is to try and detect subclinical disease that are difficult cases for the rheumatologist, or if there is a sort of borderline case or cases where there is overlapping features of both osteoarthrosis or crystal disease with underlying seronegative or seropositive arthropathy. And we can also look for treatment response and disease progression. So I just wanted to thank a couple of my colleagues, Dr. Frank Dorian, who's my current senior registrar at RPA. He helped me put together some of these slides today, and also my colleagues, Dr. James Linklater and Julie Schatz, who lent me some of the cases for this talk. And here's my health email should you wish to try and reach out to me for any discussions later on. Thanks so much.
Thank you very much, Dr. Emily. That was wonderful. In fact, a good number of our people would like to know from the basics, and you worked the way up so wonderfully well. It's a great pleasure to listen to you, really. And I must add to all the listeners that Dr. Emily Davidson has been awarded the Charles Christian Award for Excellence in Musculoskeletal Research, and it shows clearly, and the Robert Freiberg Fellowship Research Award. So your keenness in research has been apparent with your talk, and we all loved it.
Oh,
Thank
good.
you so
Thank
much.
you. Thanks,
And I know we had some little starting trouble, but still, we have really listened to an expert, and I'm really grateful to you for having participated in this particular session. And we'll work towards something more, and in both our societies, since that Dr. Tim isn't here, he has sent his apologies, being in Fiji. So we will also be playing a video of what he has wanted to tell all of us at the end of the show, because for want of time, we need to give the speakers enough time. So thank you very much, Dr. Emily. And we will go on with the next speaker. And as we conclude the program, we will announce and give Dr. Tim Dixon's video some time for him to say his message. So thank you very much, Dr. Emily. Please be with us. I'm sure there will be a few queries And we'll be happy to have you give the answers for that. There are some queries coming up, so please hold on. And over to Dr. Dharmender for his next introduction to the next speaker, Dr. Joshita Singh. Thank you so much, Dr. Emily. Yeah.
Thank you, sir. Thank you, Dr. Emily, for your insightful vision. Okay, and the next speaker is Dr. Joshita Singh. She is Senior Consultant Radiology in Jupiter Hospital, Pune. Her areas of interest are NSK and neuroradiology. She is the recipient of Dr. Ashok Mukherjee Award in 2011, and she is the past associate editor of IGRI and past president of Pune chapter MSBIRI. So over to Dr. Joshita on on your talk. Thank you. Dr. Joshita, I made your presenter. Dr. Joshita. Dr. Joshita Singh. Dr. Joshita Singh, are you listening to me?
Sir, ma'am's name in the participants list, ma'am's name is not there. Is there, sir? Presenter, you have given presenter rights
Yeah.
also. Maybe you need to unmute ma'am.
Dr. Joshita, can you unmute yourself and come on the video?
Am I audible now?
Yeah,
Yes.
you're audible, but your video is not on.
Can you
Kindly
see the
click on
screen?
video. Yeah, that's nice. We're
Can
just
you see
trying-
the screen now?
Not really. Can you share it properly, please? Yeah, now we can see it.
Okay.
Would you also
Shall I
come
begin
on
my
video?
talk now?
Yeah, please come on the video too, so that the others will see the speaker
Okay.
too.
Where? Let me.
It's all on the bottom line dashboard. You are visible now for some time. Yeah.
I'm not able to get that going, so I think I'll just start with the lecture.
Okay. Please go ahead.
Okay. If I'm audible and my screen is seen, I'll begin. And that was a really lucid lecture on inflammatory arthritis. So after that lecture, let's move on to something that we are used to seeing, which is infective arthritis. Now, what we are going to do in this lecture over the next 40 minutes is basically we'll be talking about infective arthritis of the native joints in the general population. We will cover the mode of spread and the pathophysiology of how the joints get destroyed in septic arthritis. We will understand some relevant clinical aspects and then see the radiological features. And we will do all of this by taking a look at some clinical case examples. Now, when we see the clinical cases, we will see a few cases of prosthetic joint infection and pediatric septic arthritis with osteomyelitis, but this lecture is not a dedicated focus on these two clinical sub-entities, and we will also not be talking about infective spondylodiscitis. So let's begin by understanding the disease burden of septic arthritis. The annual incidence for native joints has been reported to be about 2 to 20 per lakh population and 5 to 12 per lakh children. Fortunately, the incidence of infection is less than 1% in primary knee and hip arthroplasties. But when it happens, it's a long course of antibiotics, and often revision surgery is needed. Now, we know that septic arthritis is an orthopedic emergency because any delay in diagnosis results in increased morbidity since there is rapid destruction of the joints, and also there's a high chance of mortality. The classic symptomatology of septic arthritis is that it's a monoarticular involvement, and the patient usually presents with fever and a warm and swollen painful joint. But this classic clinical picture is not always seen, and sometimes you can have more than one joint involved. So it can be an oligoarticular disease, We know that high-grade fever can be seen in only about 58% of the patient. Joint pain may be blunted in the immunosuppressed patients, and some etiologies, for instance, fungal and TB arthritis, can have a more chronic indolent presentation. But the worst is that it can be confused with an acute flare of an inflammatory arthritis. And the reason why this is so important is because about 47%, that's nearly as good as 50% of patients with bacterial arthritis have prior joint problems. So our challenge really is to not miss septic arthritis and call it an acute flare of an underlying joint disease. Right. So let's see the risk factors for septic arthritis. We've already discussed that pre-existing joint disease is a predisposition for development of septic arthritis. That's because in all of these conditions, there's more synovial vascularity. But apart from these, there are a fair bit of other medical conditions, skin diseases, even minute breaks in the skin can result in, staphylococci and streptococci getting into the bloodstream and causing bacteremia and causing septic arthritis. Then various other conditions that can lower the immunity of the individual can predispose one to getting septic arthritis, and certain drugs, for instance, use of corticosteroids and disease-modifying anti-rheumatic drugs can all predispose one to septic arthritis. Certain other social and demographic factors, and advanced age is an important one. Advanced age is associated with higher morbidity and higher mortality. So the higher mortality and also a higher incidence of joint destruction consequent to septic arthritis. So let's understand the route of spread, how the infection gets into the joint. The commonest route of spread is the hematogenous spread to synovium during a process of an occult bacteremia. The synovium, it lacks a protective basement membrane, and that's why it is so vulnerable to bacteremic seeding. This also makes us understand why pre-existing joint diseases, where there is a little hypervascularity of the synovium, predisposes an individual to development of septic arthritis. The other mode of the bacteria getting into the joint or the organism getting into the joint is by direct inoculation, either through a penetrating trauma or during a surgery or during an intra-articular injection, and an unfortunate situation of bites, which can be either human bites or animal bites. And then again, contiguous spread of infection, either from adjacent soft tissues or from adjacent osteomyelitis, adjacent bone infection getting into the joint. So that's the three modes of spread of infection into the joint cavity. So this is an example of a patient who's had hematogenous spread. He's a 63-year-old gentleman who has chronic renal disease and is on hemodialysis. He presented to us with sudden onset right hip pain and fever and a fixed flexion deformity at the right hip joint. We've done the MR imaging, and what we can see is that there is right hip joint effusion. There's a distended right iliopsoas bursitis there. Plus, there's a lot of periarticular edema involving the muscles around the hip joint. That's the iliacus there. And there is some reactive marrow edema in the acetabulum there, also seen well on your T1 weighted images. So this patient on blood culture ended up having Staph aureus infection, and this was methicillin resistant. And MRSA is Staph aureus in general is the commonest organism, and MRSA is the one that is posing a lot of problem across the world. This is an example of contiguous spread of infection into the joint. This is a lady with uncontrolled diabetes who had presented to us with a non-healing wound along the left knee. And as you can see on the radiograph, there's some soft tissue swelling around the knee joint. periarticular osteopenia, and most importantly, you see some air foci in the soft tissues. So seeing air in the soft tissues or in the joint would be an indicator to septic arthritis. When we have done the MR imaging for this lady, what we see is that there is a large abscess, which also is contiguous with the prepatellar bursa, and this has completely destroyed the patellar tendon. There is reactive marrow edema and changes in the patella and the tibial tuberosity, plus the joint effusion, which shows thick synovial enhancement. This patient underwent a left knee and thigh debridement, and the culture showed that this was a Klebsiella pneumoniae infection, which is an anticipated organism because it's an air-forming organism, and the presence of air points towards an air-forming organism. Staph epidermidis in this case was a contaminant because it's a common skin, So let's understand how the joint gets destroyed in septic arthritis. There's a three-pronged attack on the articular cartilage, which results in eventual joint destruction. First is the bacterial invasion itself. So the bacterial enzymes and toxins, they harm the articular cartilage, eventually leading to joint destruction. And then the host inflammation, the host neutrophils release reactive oxygen species and lysosomal proteases that damage the articular cartilage. The cytokines, they activate host matrix metalloproteinases, which auto-digest the articular cartilage, and all of this results in joint destruction. And then this is the most important, and this is something that we can do something about. As the pus accumulates in the joint cavity, the joint pressure rises, and this causes a tamponade effect of the synovial blood flow, eventually leading to cartilage anoxia and therefore cartilage damage and resulting in cartilage damage. That's why the importance of getting the fluid and the pus out of the joint as early as possible to prevent tissue anoxia, cartilage anoxia, and cartilage damage. A lot of organisms have been incriminated as etiology for septic arthritis. The commonest are the gram-positive cocci, Staph aureus being the most common organism across the world. This is because it has surface adhesins that can bind with the extracellular matrix proteins, which are found in the joints, and therefore it's a common organism for septic arthritis. But apart from that, gram-negative bacilli, Mycobacterium tuberculosis, and even viral etiologies. For instance, chikungunya is a common cause for septic arthritis of small joints of the hands and feet. So a varied causative organism list. Which are the joints involved? Now, across the population subset, knee joints are the commonest joints involved. They are definitely the commonest joint in the adults, followed by the hip, followed by ankle, elbow, and the other joints. There are certain conditions where you can have specific joint involvement. So in patients with diabetes and a foot ulcer and osteomyelitis, you will have foot joint involvement. Or in injuries consequent to walking on a thorny terrain, you can have foot joint septic arthritis. Hand joints can be involved in bites, both consequent to human and animal bites. In children, there's an equal involvement of knee and hip joints in septic arthritis, comprising 1/3 of cases each, and the remaining joints comprise the remaining 1/3 of the joint involvement in pediatric population. The cartilaginous joint, they tend to get involved often in IV drug users. We also have sternoclavicular joint involvement with tuberculosis that we see often in our country, and SI joints is a common site of involvement with brucellosis. So let's now move on to the imaging features. What do we have in our imaging armamentarium? We can use all of these: X-rays, ultrasound, CT, MR, bone scans, and image-guided procedures can be done. And this I will not be covering upon because there's a subsequent lecture on it. Ultrasound and CT has a very critical role for the image-guided aspirations. The radiographic features are something that we must know. it's important to remember that early in the disease course, X-rays may be normal. For instance, in this girl, which we have seen very recently, this is a 4-year-old girl, no history of trauma, sudden onset presentation with fever and swelling around the ankle joint. This was the radiograph done the next day in the morning following the onset of the illness, which is fairly normal. And a few days later, when we have done the MR imaging, we can see that there is septic arthritis of the ankle joint as well as calcaneal osteomyelitis consequent to Staph aureus infection. And this was methicillin sensitive Staph aureus infection. So remember that early on in the disease course, X-rays may be normal. But when abnormal, X-rays can show joint effusion, they can show soft tissue swelling, as in this case, periarticular osteopenia, erosions, as in seen here. And as the disease progresses, then there can be destruction of the articular cartilage and narrowing of the joint space. The hallmark on radiographs for septic arthritis is a rapidly progressive joint destruction. As you see in this case, this is an example of a prosthetic joint infection. This is a 77-year-old lady who'd had a TKR done about 10 years ago. She presented at another hospital with diabetic ketoacidosis and urosepsis. The urine culture had shown E. coli. She also developed there itself knee pain and swelling and was referred to us for further management. This is the radiograph we have done when she presented to us. You can see that there is some joint effusion there. Since she was symptomatic for it, she was advised aspiration of the knee joint, and then if necessary, a revision arthroplasty, but she wasn't consenting for the procedure. I must point here that she was already on appropriate antibiotics since the organism had already been isolated at another institute. So she took a discharge against medical advice, but soon came back 10 days later with a discharging sinus in the infrapatellar region. And you can see that the joint effusion has increased. There's soft tissue swelling there, and there is also a lot of destruction. Now compare it, these are just 10 days apart radiographs. There's a lot of erosion along the tibia there. And now she consented for the surgery. So revision TKR was planned. This is the first stage where the implant was removed and antibiotic impregnated cement spacers were put in. Unfortunately, she didn't survive much beyond this, and a complete revision arthroplasty could not be done in her. Now, whenever you read on septic arthritis, there are examples of closed fist injuries that are always talked about. We don't see it so often. So I've taken these examples from literature where when you see a dent in the metacarpal head, as in this case, you know that there's been a violation of the joint capsule, and there is likely to be, in this case, who's had a closed fist injury a few days ago, you see rapid destruction. There's a narrowing of the joint space, and the cortical white line, compared it to the other metacarpal heads, the cortical white line is not identified in this metacarpophalangeal joint, and you know that there is septic arthritis. Now, we don't really see closed fist injuries so much. Maybe the bad guys are getting wiser and they know it's more effective to hit below the belt rather than punch a person in the face, or also possibly because of the increased use of firearms and weapons in fights. The role of ultrasound. Ultrasound is an easy, cost-effective modality for accessible or superficial joints. It shows effusions well, it shows synovial thickening very well, and when you see periarticular collections, your confidence level of septic arthritis really goes up. It also works as a wonderful image guidance for aspiration and biopsy. So this is a case that has been lent to me by my colleague, Dr. Joban Babulkar from Pune itself, who's also an MSS member. This is a patient with post-Bankart repair joint infection presented with fever, pain, and leukocytosis. What you can see is a complex joint effusion, a lot of synovial hypertrophy with hypervascularity. And another case that has been lent to me by another MSS member from a neighboring city of Mumbai, Dr. Ankit Shah, just to highlight the very good role of ultrasound when it is done by a good radiologist with good equipment. This is a patient who's had an arthroscopic cuff repair 2.5 months ago and now has a discharging sinus. And what you can see is the osteolysis around the anchor and the periarticular collection and the sinus tract really so well on these ultrasound images. And again, another patient which has again been lent to me by Dr. Ankit Shah of TB arthritis. On the MR imaging, you can see that there is joint effusion, synovial thickening, and a lot of edematous changes in the periarticular bone. He's gone ahead and done a synovial biopsy, and this ended up being a TB arthritis. So ultrasound can work as a good modality for guidance when the joint is superficial and accessible. But when the joint is deep-seated, the role of CT really comes into play to access the joints. What you see on CT in septic arthritis, the imaging features are actually fairly similar to radiographs, but just slightly better, particularly when you're looking at erosions. And also you're actually able to see the effusion directly. Certain joints, there is a definite advantage of higher modalities like CT and MR, for instance, the sternoclavicular joint, which is very suboptimally assessed on radiographs. For the deep joints, of course, CT and MR works really well. So this is an example here of left sacroiliitis, a young woman who presented with fever and sudden onset gluteal region pain. We have done dedicated SI joint imaging because there was a clinical suspicion of sacroiliitis. And what you can see is marrow edema that shows enhancement in both the sacral and the iliac aspect of the SI joint, along with a periarticular abscess. And we've used CT to aspirate this and drain out this abscess, and this ended up being an MRSA septic arthritis. Let's now come to the imaging modality that's used most often, which is the MR. Fortunately, in our country, there's a good availability of MR, and there's not a very high waiting time for an MR appointment. Even in our second and third tier cities, MR is freely available, and that to good equipments. So we end up using MR pretty often in the diagnosis of septic arthritis. The advantage of MR is that it's abnormal early in the disease course, becoming abnormal as early as 24 hours within the onset of symptoms. It's also excellent for localizing the infection and for showing the extent of involvement of the bone and soft tissues. What you see on MR is effusion, bone marrow edema, erosions, periarticular edema or collections, synovial thickening, and since the joint is under high pressure as the pus accumulates, you see synovial outpouching and synovial recesses opening up, which also show enhancement, just like the synovial membrane of the joint cavity itself. And then as the disease progresses, you can visualize articular cartilage destruction and joint space narrowing. The problem with MR is that it lacks specificity. You cannot often differentiate between a septic arthritis and an acute flare of an inflammatory or crystal arthropathy. For instance, this is an article by Unital where they looked at the MR findings between patients with septic arthritis and acute gouty arthritis, and they concluded that the differentiation is difficult. However, they pointed out that lamellated synovial thickening patterns, bone marrow edema, and soft tissue abscess formation was more common in septic arthritis than in acute gouty arthritis. I must make a point here that lamellated synovial thickening pattern is also the thickening pattern that we end up seeing, and that points to an infection when we are evaluating or doing MRs for prosthetic joint infection. Another article published a little earlier in Skeletal Radiology, where they've looked at MR features of septic versus non-septic inflamed joint. And again, they found that no single sign or combination could be either pathognomic of septic arthritis or could actually confidently exclude the presence of joint infection. So the bottom line is that you must have a high clinical suspicion for an infective process and septic arthritis. And whenever you aspirate a joint, you must send it not just for the crystals and for other evaluations, but also for a culture and for microscopy and culture and sensitivity, and also for evaluation of tuberculosis. Talking of tuberculosis, the presentation in tuberculosis is often a chronic indolent type of presentation, and that is why you get the imaging features that you get. So the phimostis diet, where you have a regional periarticular osteopenia, marginal erosions, and a relatively preserved or a gradually reducing joint space. All of this just points to the fact that it's a chronic indolent, a slowly progressing process, and therefore the joint space has not gone rapidly going down. This was an interesting article that I've seen in radiology, where they've tried to differentiate tuberculosis from pyogenic arthritis, and they found that bone erosions and the absence of subchondral signal abnormality and smooth margins of extra-articular collections favored TB over pyogenic arthritis, while in pyogenic arthritis, the extra-articular collections tended to have a more thick and shaggy margins. Again, this is just a pointer to the fact that TB has a chronic indolent process, and the body has had time to react to it, and that's why the disease process is a little slowly progressing, and not so much of subchondral changes. As you can see in this example of TB arthritis at the elbow joint, you see a lot of synovial thickening, you see some erosions in the radial head there, but note that there's not too much of pronounced marrow signal abnormality in the periarticular bones. So having done that little theoretical overview, let's now move on to seeing a few cases, and we will stop whenever the the 40-minute time frame is over. So the first case, this is a 30-year-old lady, fever since 8 days, has some constitutional symptoms, nausea, giddiness, and headache, has presented to us with right hip pain and difficulty in moving the right hip joint. On examination, she has some terminal restriction of movement. Clearly, she has systemic signs of infection. While there's no leukocytosis, ESR and CRP is markedly elevated. When we've done the imaging, what we see is joint effusion. We also see there's a lot of periarticular edema involving the muscles around the hip joint, and there's also involvement of the bone with signal abnormality, both on your STIR images as well as your T1 weighted images that shows enhancement. Now, the reason to put this case is that always seeing signal abnormality on T1 weighted images should not make you think about osteomyelitis. You can also have reactive edema, which will manifest itself as hypointense on your T1 weighted images, just that when there is osteomyelitis, this signal intensity is a lot more pronounced than when it is in reactive edema. So she underwent right hip debridement, and this was found to be Staph aureus, again MRSA, and therefore lavage and antibiotic cement bead placement was then, and these are post-procedure radiographs. She was followed up when treated with appropriate antibiotics. A follow-up blood culture showed no growth, and the inflammatory markers were declining, and therefore we were able to control the disease well. Moving on to our second case, and this is an interesting case. This is a young lady who presented with fever, with chills, and sudden onset pain and swelling around the medial aspect of the left elbow joint. On asking the history, she'd had a recent travel to another country where she'd had a extremely fun holiday, done a lot of fun activities. So actually from the history, we thought, are we going to be looking at some exotic organism that is not familiar to our terrain? When she presented to us, she had a fixed flexion deformity at the elbow joint. She had no leukocytosis, but ESR was a little high and CRP was also a little high. When we've done the imaging, this is what we've seen: joint effusion at the elbow joint. You can see enhancement, synovial enhancement of the joint cavity. Again, not much of bone marrow involvement, but there is some periarticular edema there. But what she also had, and the reason for the fixed flexion deformity, was this involvement of the brachialis muscle, where you could see a lot of myositis with a focal collection in the muscle itself. And as I said earlier, we were really hoping that this would end up being some exotic organism that we could treat well and establish the diagnosis. But to our surprise, this patient underwent an aspiration of from that intramuscular abscess and a muscle biopsy. The pus swab, which is not a good thing to do because it's always better to get fluid rather than a swab, which the yield on a fluid when you do a culture is a lot better than a swab. But the pus swab in her grew gram-negative bacilli and E. coli was isolated. However, the biopsy showed some eosinophilic infiltrate. So what we postulated was that while she was having fun and eating out, maybe she must have had some sort of parasitic GI infection, and that infection allowed the easy translocation across the bowel mucous membrane for the E. coli to get into the the blood circulation and eventually result in septic arthritis. A third case, this is a young man post-liver transplant status who's unfortunately not doing too well. He's had 2 duct anastomosis, has had an anastomotic stricture at one of the ducts, and has had an ERCP with stenting done for that, and has now presented to us with graft rejection, for which IV steroid pulse therapy was given. He presented to us in October 22. Had some backache, and MR of the dorsal spine was done, which was unremarkable. But the workup showed that he had clear infection. There was neutrophilic leukocytosis, the procalcitonin levels were very high, and the PCR as well as blood culture grew Klebsiella pneumoniae. So we knew that we were dealing with a patient who's got Klebsiella pneumoniae sepsis. 2 months later, he presented to us with pain and swelling at the right knee joint. This time again, he had neutrophilic leukocytosis, CRP was still high. So the knee joint fluid was aspirated, and again, it grew Klebsiella pneumoniae. So a right knee arthroscopy was done. Synovectomy, debridement, and antibiotic cement beads were inserted, and we hoped that this would heal well. Unfortunately, that didn't happen. 2 months later, he was still very symptomatic at the knee joint. These are the initial x-rays when he presented to us, and the 2 months later radiographs. And you can see that there's an increase in the joint effusion, but there's not too much of change in the periarticular osteopenia. That's possibly because he's already on appropriate antibiotic, and the treatment was instituted early in the disease presentation. So this time round, we went ahead and did an MR. And when we did the MR, what we see was that there was a lot of effusion, a lot of synovial thickening, which was lamellated and rather frond-like in the suprapatellar bursa there. A lot of synovial thickening there. That's the PCL rhesus, which is now opened up. It's almost taking a heart shape there. But apart from that, there were bone infarcts, and these were likely consequent to the steroid therapy that he had taken. Now, what do you talk about and describe the bone signal abnormality as? Is this all just bone infarcts, or are we also looking at coexistent infection? It's always a little challenging in such a scenario with such extensive involvement. So this patient underwent knee arthroscopy and synovectomy, again with the antibiotic bead placement, and these are the post-procedure radiographs. But because we wanted to know whether the bone was also involved with osteomyelitis, so a tissue, there was also a biopsy of the synovium and bone done. The culture on that was negative, but the synovial fluid did grow Klebsiella pneumoniae again. So this was a resistant Klebsiella pneumoniae despite appropriate antibiotics. 1 month later, he came back with cholangitic abscesses, and this time round, when we did the ERCP, we removed the stent that was placed in, and that stent was actually acting as a source for repeated infections. So once the stent was removed, we could tackle the general Klebsiella infection across the whole body, as well as the septic arthritis of the knee joint well. So that's an important take message from this case. Another example, a young girl who's had a trivial fall while playing in the park, over the left knee joint and is presented with swelling and fever. Clearly an infection that is involving the leg. So we've gone ahead, and you can see on these radiographs, there's soft tissue swelling there, but nothing really else in the bone, or not in suggestion to a knee joint effusion either. We've gone ahead and done an MR for her, and you can see that there is metaphyseal involvement, osteomyelitis there with a subperiosteal and soft tissue abscess. But note also that there is involvement of the epiphysis compared to the contralateral epiphysis, and this epiphyseal involvement is not a contiguous type of involvement. There's no direct communication through the physeal bridge. There's also knee joint effusion with enhancement. So this is septic arthritis along with osteomyelitis. In fact, there's a school of thought that believes when there is knee joint effusion in pediatric patients with adjacent metaphyseal osteomyelitis, you should treat the effusion of the joint as a septic arthritis. You can see the periosteal, the periarticular abscess that shows a fat pus level, and that's a diffusion restriction of the purulent material. So an extensive drainage and debridement was done for her, and this again was an Staph aureus MRSA involvement, and this is the appropriate antibiotic were changed once the culture sensitivity report came back, and she was managed well. And this is just a radiograph a month later where you can see lamellated periosteal reaction consequent to the osteomyelitis. Again, another case, and this is the last case, and I will end after that. This is a patient who had diabetes and had dengue fever, and then presented with some constitutional symptoms else to another hospital, and had a right gluteal region abscess, for which an IND was done, and both the purulent material as well as the blood culture showed that this was an E. coli infection. They kept trying to manage this right gluteal region abscess a little unsuccessfully, and then the patient was referred to our hospital, where you could see that there was a clear sign of systemic infection. Neutrophilic leukocytosis, very high CRP, procalcitonin was also very high. A CT was done to look at the status of the infection, and it showed a large iliopsoas region abscess, for which a pigtail drainage was also done. So this is just to show you us the pigtail drainage catheter in that large iliopsoas abscess. But we wanted to evaluate the cause of the iliopsoas abscess, and therefore we went ahead and did the MR, and lo and behold, there was no involvement of the vertebra there. This was not an infective spondylodiscitis from the vertebra and then iliopsoas abscess. This was actually sacroiliitis, and that information was really not evident on the CT, even after a second look evaluation on bone windows. And so you can see that there's a lot of marrow involvement along the SI joint effusion, and a whole lot of abscesses, not just the iliopsoas one, but but smaller abscesses along the piriformis muscles, and the iliopsoas abscess was even tracking down into the thigh region. So a combined imaging method allows us to stage the disease well for these patients, therefore allowing a good prognostication, and also allowing good drainage of all the large abscesses that would otherwise not heal to just IV antibiotics. An IND of the large abscess was done, and appropriate antibiotics were given. Unfortunately, because of the large disease burden, she subsequently developed septic shock and multi-organ failure, and we lost her. So to conclude, what we have done over the past 40 minutes is we've seen cases of infective arthritis involving the native joints, and what we've realized that there should be a high index of suspicion to diagnose these early, and we have to act early whenever we are thinking of septic arthritis. We've seen the radiological features and how combining that to clinical and lab workup can lead to appropriate diagnosis and timely intervention. With that, I conclude my lecture.
Thank you very much, Dr. Joshita. That was superb. Really, I think we have a large cross-section of cases and you have appropriately delineated all the fine points in what we should do for every septic arthritis. Thank you very much. And we look forward to maybe asking a few questions. Are there any, Dr. Dharminder?
Yeah,
Chat box? Yeah.
Dr. Josita, very lucid talk and very nice, insightful presentation of yours. And one question from Dr. Stanjit from Delhi. She was not able to type in chat box, but she has messaged me. How common is sequestrum formation in tuberculosis? And can that help differentiate septic versus tubercular osteomyelitis?
No, I couldn't hear the question. Can you, or
Okay.
can I see the question?
Second, one question from
Oh, sorry.
Dr. Okay, one question from Dr. Stanji of Delhi, no, New Delhi. She asked, how common is sequestrum formation in tuberculosis? And can that differentiate the septic versus tubercular arthritis?
So the thing is that it's not easy to differentiate TB versus septic very easily on imaging. Of course, if you see more, T2 dark signal in the synovial hypertrophy, you could favor tubercular etiology. But the point or the take-home message should be that whenever you see and whenever you're aspirating a joint in the setting of septic arthritis, you should send it not just for your gram stain, but also for your AFB stain, and the culture should also be done for both TB and for the bacterial organisms. So your workup, your lab workup should include both, and it should be a routine practice to do both, including PCR testing for TB, which is what we do, because you know that TB is a big mimicker and it can look like anything, and we cannot afford to lose on time and not initiate treatment early in these patients.
Okay, thank you so much. So now, thank you, Dr. Joshita. I made Dr. Padma your presenter, and now I'm going to introduce Dr. Padma. Okay, Dr. Padma Menon has graduated from Government Medical College, Kottayam, Mahatma Gandhi University, India in 2010, and she was awarded FRCP from the Royal College of Radiologists, London, UK in 2017. After moving to Australia, Padma completed breast imaging fellowship in 2020 and another in body imaging in 2021. She achieved membership of the Ranger in 2021. Padma works in the private practice with the Perth Radiological Clinic since 2021. Okay, her topic is post-treatment imaging in arthritis, what a radiologist needs to report. So, Dr. Padma, over to you. Dr. Padma, you unmute yourself.
Hi, can you hear me?
Yes, please. Go ahead. Kindly go ahead.
Sure. So I might just add on that I'm post-fellowship trained in MSK. I did a full year, actually 2-year MSK fellowship at Perth Radiological Clinic, which is a very big private practice in Western Australia. So that's my topic today, post-treatment imaging in arthritis, what a radiologist needs to know. Can I get some help? I'm not able to transition between slides here.
You make a full screen, I think.
You have to put it on a slideshow presentation. That might help, I think.
Presentation.
Yeah, it's on it. No,
Yeah, it is on a slide.
Oh, then just switch off. Try again, please. Are you getting it now?
Oh yeah. Sorry about that.
Okay.
So when we start reading rheumatology literature, it's quite overwhelming, the number of criteria, the organizations, and the n number of things that comes with rheumatology literature. I've actually tried to stay away from all this, which is not important from a clinical perspective. I've tried to keep it really simple to just focus on what we need to know as reporting radiologists in the imaging of a treated joint. For this purpose, I've tried to divide the topics that I'll be discussing today into these subheadings. and try to discuss the role of imaging in assessing these. So I think it might be prudent to spend a minute or two to just try and figure out what each of these subheadings means. All of us are aware what disease activity means. In the case of rheumatoid arthritis, active disease would mean the presence of osteitis, which is evidenced by bone marrow edema, synovitis, tenosynovitis. In the case of axial and peripheral spondyloarthropathy, this would be the presence of, again, osteitis as evidenced by bone marrow edema, enthesitis, arthritis, or capsulitis. So that's active disease. Not much to explain there. We will discuss this further in the coming slides. Structural so it is either uncontrolled active disease, spondyloarthritis. It would mean presence of erosions, in addition marrow infiltration with fat, sclerosis, and ankylosis in the case of axial and peripheral spondyloarthritis. So I think the points that I wanted to discuss further would be the prediction of outcome and severity and prediction of treatment. When you look at it cursorily, it looks pretty similar, but I think there is a little bit of a difference in which when you're trying to predict outcome or severity, you're trying to, at the start of treatment, you're trying to figure out what this patient's disease severity is going to be at a point B, which might be 2 months, 6 months, 1 year from start of treatment. And while we try to predict treatment effect, what we're trying to predict is at start of treatment, are there some imaging features which might tell us that this patient is going to be difficult to manage, it's going to be aggressive disease, and do we need to initiate some kind of aggressive treatment? So that's the difference between those two. Well, it's a bit different. Again, complications, which is self-explanatory. We'll start off with rheumatoid arthritis. For the purpose of my talk today, I'll be discussing rheumatoid arthritis, peripheral and axial spondyloarthritis, and infective arthritis. So the current concepts in treatment are the window of opportunity, which has already been discussed. And this window of opportunity for 3 months does not mean that it comes to the clinician after that period treatment is not given. Surely it is, but it is best to disease, and this is not the outcome we want. Every patient who comes to us should not go into this outcome, which is why we try to treat it early. So the clinicians have a treat to target phenomenon in which they set a clinical target and the aim of treatment is to achieve that target. So this target is based on clinical response and not imaging. So boils down to the role of imaging being in cases where there is diagnostic uncertainty, suspected subclinical active disease, or complications, which is pretty much like a problem-solving tool. So it would be prudent to mention that subclinical activity can actually keep destroying the joint without overt clinical disease and lead to the complications which we don't want, including the structural changes of erosions and deformities. So the fact that the management of rheumatoid arthritis is mainly clinical, this outcome has been decided based on several studies. The best of these is probably the Imagine RA study, which happened in Denmark over 2 years from 2012 to 2015, and 200 patients in clinical remission, which was guided by a clinical guideline, where had MR as well as clinical treat to target strategy, and the outcome was that MRI guided treat to target strategy was not beneficial in comparison to a clinical treat to target strategy. So what is the role of ultrasound or MRI? These are the commonly used imaging modalities in the case of post-treatment arthritis. As I've said before, when there is a suspicion of subclinical disease or complication, or when the clinical diagnosis itself is not clear. So what are the, what is it that we look for? So presence of active disease, I've already described. Active disease is characterized by bone marrow edema and synovitis, and it would be imperative to get imaging to identify the location of active disease or inflammation, and again to look for structural changes, which are erosions. So in a patient with diagnosed rheumatoid arthritis, the role of assessment of structural changes is to look for disease progression. It's not the diagnosis per se, it's to look for disease progression. And it is these roles, the yield of imaging is quite significant in any arthritis, and clinical trials are ongoing to best incorporate imaging findings into future remission criteria. So this is a classical example. There are no bone erosions, no soft tissue edema. So this patient had clearly, and clinically the patient did not have active disease. But on MR, there is a small volume DRG fusion with synovitis, as evidenced by these front light projections. On post-contrast imaging, there is enhancement in keeping with active synovitis. There is also enhancement in the radiocarpal joint and in the midcarpal joint. So this patient went on to have more aggressive treatment than he would normally have had, which is a win of imaging over clinical assessment, I would say. Again, the role of ultrasound helps to characterize small volume effusions, tenosynovitis quite easily. Ultrasound is readily available. So the role of radiographs is in monitoring the progression of erosion. So once the patient has had structural disease, the role of radiograph is to monitor disease. So there's no point in a radiologist looking at treated rheumatoid arthritis and saying there is an erosion. The idea is that you compare with priors and say if the erosion looks similar, it has progressed, are there new sites of erosion, are there new changes to suggest active disease? So that is our role, where we go that higher, one step forward than a general radiologist. This is quite interesting. Quite rarely, in about 7% patients following treatment, particularly with biologics, erosions have been seen to heal. That's normal bone marrow, which has replaced the change of erosion, the fibrotic scar of erosion in a patient who was treated with for rheumatoid arthritis. This is another interesting case. So this lady was a 51-year-old lady who had a history of juvenile rheumatoid arthritis at 7 years of age and was treated for this. So she first presented in 1998 with severe right hip pain. So there was a background of this lady having had bilateral total knee replacements and a left hip arthroplasty as well. So this is 1998. And on this radiograph, it shows that the joint is severely destroyed, severe joint space narrowing, and secondary degenerative changes. There are erosive changes as well, in addition to changes of severe osteoarthritis. So this was 2008 when she again came with worsening symptoms. So she had an interim radiograph which was performed at some point between these two, at which time she was in clinical remission. So when I'm looking at these radiographs, this last radiograph in 2008 looks much better to me than the radiograph in 1998. Even so, the radiograph in between looks better than the one in 1998. So that's a bit baffling. So what's happened here? So that is what this article tries to discuss. Do these findings indicate true repair of the joint? So this lady went ahead to have a hip arthroplasty, and what came out of the arthroplasty was that though the joint space is preserved here, there is improvement of the subchondrocystic change, and the joint space looks better. Like, I wouldn't say preserved, it looks a lot better than it is on the prior two radiographs. What has happened is she has had healing, but this is fibrocartilage rather than hyaline cartilage, which is the normal cartilage lining the large joints. So the next subheading we would discuss would be the prediction of outcome. So rheumatoid arthritis, as I said, it's basically a clinical diagnosis, a clinical, the management is also clinical and mostly clinical. And the outcomes they talk about are remission, functional limitation, or joint damage. So The early presence of structural damage is the role. We assess this using radiographs, and that's where imaging comes into play in the prediction of outcome. The other two criteria are clinical. So DAS28, CRP 5.1. So that's disease activity score in 28 joints and a CRP. So they use kind of a complex calculator to measure what this is. If that's more than 5.1, that's a poor prognostic factor. That's a clinical criterion. Again, positivity for the rheumatoid factor and the CCP antibodies, and as we said, presence of structural change. There's this recent study which has been performed in 2022 with 35 patients with early rheumatoid arthritis. They've used a fancy kind of a PET, which is a macrophage tagged PET of the shoulders, elbow, hips, knees, hands, feet, and they've tried to image these joints at 0 and 2 weeks post-treatment and compared with clinical response at 13 weeks. So imaging at 2 weeks and a response at clinical response at 13 weeks. So the disease outcome was measured using DAS44, which is disease activity score in 44 joints at 0, 2, and 13 weeks. And apparently this came back with really good results in saying that DAS44 after 2 weeks of this treatment, which is called Cobra Light, correlates with clinical response at 13 weeks. So we get to know at 2 weeks what the patient is going to behave using this PET CT, and it's the feet joint that they found to be of best use. But the clinical and the practical implications of how we can use this fancy PET study and how available it will be, and from a practical point of view, when it would be possible for as a large scale available device. So this is another RAMRIS, which is another scoring system, which was developed by OMRAT, which is rheumatoid arthritis MRI scoring system. So there is RAMRIS 23, which uses 23 joints of the hand and assesses presence of osteitis, synovitis, tenosynovitis, and bone erosions in these 23 joints in response to treatment, which is quite exhaustive and extensive and takes a lot of time, which has paved way for RAMRIS 5, which makes use of 3 commonly affected joints in the hand. So again, as I said, this is all in clinical trials and not yet in, or would probably not even come into clinical practice for a long time to come. We could now discuss a few complications wherein I'll show some of our images. So this was a 59-year-old male who was a known case of treated rheumatoid arthritis in clinical remission. He presented with pain, swelling, and erythema of the ankle. So the request was query fracture, query osteomyelitis. So radiographs of the ankle and foot were performed. So the ankle looks pretty okay to me. The joint space is really well preserved and probably a very small volume joint effusion. But I'm looking at the feet joints. You can see that there are chronic structural changes of rheumatoid arthritis in erosions involving the MTP joints, the 2nd, 3rd, and 4th and 5th MTP joints. But there's nothing to suggest active disease at this stage in the form of soft tissue swelling. So it was pretty much a non-specific radiograph other than the fact that he has prior erosions. Went on to do ultrasound, which revealed a small volume ankle joint effusion. This was aspirated and Staph aureus. Well, so that is septic arthritis. He went on to have a bone scan, which showed increased uptake in the involved ankle joint. There's also some uptake in the left wrist, which was evaluated radiographically. He didn't have symptoms of any active process there, and this was proven to be degenerative arthritis. So the ankle joint, we focus on the ankle joint. He went ahead with an MR. The post-contrast images show active synovitis and inflammatory changes in the joint. At this stage, the cartilage looks relatively well preserved. So we also made note of a medullary bone infarct in the distal tibia. So that was March 2014, and the patient underwent multiple arthrocentesis. Follow-up imaging in April 2015. So that's what the joint looks like at this stage. So at this stage, it does not have any active changes, but the joint space is globally reduced. The cartilage, there's diffuse chondral thinning, and the cartilage looks darker than it was on the prior, which is probably fibrous change, fibrocartilage or fibrous change. So that's a complication of septic arthritis that we have. Yeah, that's it. So this is actually a really simple case, but I think in this whole discussion, this would probably be the most important point that I would like to highlight, that septic arthritis, as already discussed by the previous speaker, septic arthritis has a predilection for damaged joints. And in rheumatoid arthritis, the risk is very high of getting septic arthritis. So there needs to be a high index of suspicion for septic arthritis. And the real problem arises when the patient has active arthritis, bone marrow edema everywhere, and there is a clinical suspicion of infection as in osteomyelitis or septic arthritis. What do we do in that stage? That's the real question. That is a diagnostic dilemma we all face. But I think there's no straightforward answer as to what is right or wrong in that scenario. We just have to go back to basics. If there is if there is a joint fluid, it would be very helpful. We can aspirate it, and that would be a starting point. But if there is no effusion, then it again becomes tricky. Then other imaging modalities and clinical correlation, following up how the patient goes clinically with treatment. So I think that's a difficult one, and it's something we all deal with in practice. So this next patient had a rip-roaring, very active, very angry-looking arthritis and synovitis with lots of erosions. And where's the cartilage? It's all gone. There's hardly any cartilage left in the radiocarpal or intercarpal, or even probably some CMC joint, articular cartilage preserved. So there's not much to do here in this stage rather than fuse the joint. So that's Sawe-Kapanji procedure, where the radiocarpal and the carpal joints have been fused, and the head of the ulna has been excised with prosthesis. So that's probably the most important complication of treated rheumatoid arthritis by itself. Now, the most common drug which is administered in rheumatoid arthritis is methotrexate, and methotrexate has a relatively good tolerance profile, but sometimes some complications do occur, in which case the treatment will have to be discontinued or the patient goes into severe outcomes. As in this case, this patient had, you can see that there is a UIB pattern of interstitial lung disease and a background of rheumatoid arthritis. Patient treated with methotrexate develops an acute febrile illness and rapid progression into widespread airspace infiltrates, moderate volume right side and a small volume left sided pleural effusion, all this pointing towards an infection. The patient was diagnosed to have influenza. This patient did not survive, unfortunately. Again, relatively rare, and honestly, I've not seen this in my practice, but came up in literature. A rare side effect of methotrexate therapy was methotrexate-induced osteopathy. So this is the typical distribution of what looks like insufficiency fractures in the distal tibia or calcaneum or the tarsus, in that order. So the question arises, why are these not just insufficiency fractures, or why do you want to give it a separate name as methotrexate-induced osteopathy? Fair enough, fair point. But I think the point to mention here would be that this entity was first observed in children who were being treated with methotrexate for leukemia, and which is probably a good reason to think that it is not the underlying osteopenia which is predisposing the fractures, as we know that most patients with chronic inflammatory arthropathy also have associated osteopenia. So this pattern is quite typical. Insufficiency fractures in the distal tibia. It can also occur in the proximal tibia, calcaneum, and in the rest of the tarsal bones. Again, patients on long-term treatment for inflammatory arthritis have a predisposition to osteopenia, and these patients are usually placed on bisphosphonates. So bisphosphonate-induced osteonecrosis, relatively rare, but methotrexate is an independent risk factor for this phenomenon as well. So biologics are all over the place in the treatment of inflammatory arthritis. So what do biologics actually target? They basically target the TNF-alpha molecule, which is the predominant response of the body in granulomatous, like type 4 inflammatory response, which is the body's defense against granulomatous infections like tuberculosis and fungal infections like Candida. So patients on biologics, these are this is what happens. Patients get these infections like tuberculosis and candida, which are quite difficult to treat, especially in the setting of immunosuppression. So that's what I would like to discuss about rheumatoid arthritis. We move on to axial spondyloarthropathy. Again, similar subheadings, current concepts in treatment, same window of opportunity of starting treatment early. But again, as opposed to rheumatoid arthritis, in axial spondyloarthropathies, imaging takes center stage in both diagnosis and monitoring of treatment response. Similar headings, I'll discuss the topic further under similar headings. So active lesions in axial spondyloarthropathy, bone marrow edema, enthesitis and capsulitis, chronic structural lesions, erosions, sclerosis, fatty replacement or backfill, and ankylosis. So the first subheading would be monitoring activity. These images like obtained at baseline and week 6 clearly demonstrate how treatment has reduced the disease activity, as in visually looking at the amount of bone marrow edema in the sacroiliac joints bilaterally has significantly reduced by week 6. This patient is on NSAIDs. Similarly, a patient post-treatment with TNF-alpha inhibitors. This is start of treatment, week 12 and week 24. By week 24, there is significant or clearly bone marrow edema in the sacroiliac joints on both sides of the joint. And there is this phenomenon as in fat infiltration of the marrow. That is backfill. So compared to week 12, you can see that week 24, there is fatty infiltration of both the sacroiliac joints. And also, if you look carefully, there are erosions in the of the sacroiliac joint. Having said that, structural lesions as in erosions and fatty infiltration, erosions basically are monitored using radiographs, and that is the NYHA. I've just taken the NYHA to show the progression. This has previously been discussed. I wouldn't go into the details, but when you know you have grade 3, that's clearly abnormal. Grade 2 is mildly abnormal, and this is grade 1, suspicious. And grade 4 is fused. So the disease outcome or severity in axial spondyloarthropathy, there is no need to image the spine for the purpose of diagnosis. But when we want to find out the severity or the disease outcome, it's helpful to get either radiographs of the spine in which we can see the syndesmophytes, which indicate the presence of corner-inflammatory lesions, or even MRI can be very, very helpful in identifying these corner-inflammatory lesions, these enthesophytes, or even the discovertebral changes called the Anderson's lesion. So the presence of spinal disease heralds a more severe outcome. So this patient with multiple spinal level involvement, clearly very severe disease at start. 1 year treatment with biologics, there's been really good response. So this is quite key, that this is quite a key contribution that imaging can give in the treatment of, in measuring treatment response. This is quite interesting. I came across this study in British Journal of Radiology, published in 2023. They've used a beach tool, which is bone edema and adiposity characterization with histograms. They've used diffusion-weighted imaging and ADC to measure edema, and chemical shift imaging and PDFF to measure fat. So the good thing about this, in my opinion, is that all these sequences are not really time-consuming to acquire, and there is no requirement for contrast. And they've kind of tried to characterize pre-treatment. This histogram has 2 peaks, where the first peak shows edema and the second peak shows fat infiltration. Following treatment, there has been a shift to the right with increase in fat infiltration and a reduction in edema, though edema is still present. I think that would be a really, really helpful tool to add on to our armamentarium. And that's called BEACH, bone edema and adiposity characterization with histograms. As a Western Australian, you talk about beaches. I really cannot go ahead without putting this picture in here. This is Lucky Bay in Esperance, one of our beautiful beaches, which has been named the #1 beach in the world. Again, going on to complications, very helpful. CT is very helpful in identifying fractures for which these patients are prone because of the rigidity of the spine. And MR contributes by showing the presence of this hematoma, spinal canal stenosis, and cauda equina compression here. So peripheral spondyloarthropathy, we discuss under the headings psoriatic, reactive, and enteropathic. And unfortunately, this is the state of affairs for peripheral spondyloarthropathy. This is an article published in February 2020, which says it's a neglected entity, for which there are no unifying guidelines for predicting outcome or severity or treatment response. We can still monitor activity using ultrasound and MRI and monitor structural change using radiographs. So this is one of our cases from 2010. This is case courtesy Dr. Bill Bridle. So this patient had psoriatic arthritis. This is an erosion and active arthropathy with hyperemia and synovitis, no joint fusion. And that's one of my cases from 2 weeks ago. This patient has localized soft tissue swelling, and MR revealed bone marrow edema and soft tissue changes. This patient had nail dystrophy clinically, so this was diagnosed as psoriatic onychopachydermoperiosteitis. So that's to do with the inflammatory arthropathy. Now I move on to infective or septic arthritis. This is a really rapidly progressing disease, as one of the earlier speakers have said. So technically, post-treatment imaging is basically to look for complications. Complications of septic arthritis are osteomyelitis, osteonecrosis, and secondary osteoarthritis from an imaging perspective, and clearly sepsis and death from a clinical perspective. Eventually, the joint gets destroyed and ankylosis is the outcome if not adequately treated. So this was one of our patients who had a swollen finger following a penetrating injury 8 months ago. July 2013 shows a large complex joint fusion with synovitis and erosions in the center as well as the margins of the joint. Post-contrast imaging revealed contrast enhancement with abscess formation. So this was October 2013, a few months afterwards, and you can clearly see that the erosions have progressed and the joint space is narrowed, suggesting that the disease is active. So joint is being destroyed. So that's the complication of septic arthritis. And this was a 41-year-old lady who had a history of septic arthritis in the left hip in childhood with an ankylosed hip joint. So that's my talk, my heartfelt acknowledgement to my mentors and colleagues at Perth Radiological Clinic, Dr. William Bridle, Dr. Jackie Thompson, Peter Council, and Rob Nang. Thank you.
Thank you very much, Dr. Padma. That was really very nice of you to give this wonderful presentation with all the references, and that's really useful. And you have taken a solid effort to do this for us, and thank you very much from all of us here. We are enjoying the current presentations, which are very focused on arthritis, and your talk was excellent on how we must go about with looking at the prognosis and the treatment responses. Thank you so much. And please be on. I think there are a couple of questions. Dr. Dharmendra, would you like to just ask the questions, or should we put it on the chat box?
Sir, we will reply on the chat box. Dr. Padma, you please handle some questions from the chat box. Okay. And we are really, I appreciate the effort you put into sharing your knowledge with us. And thank you. Thank you so much, Dr. Padma. So going to Dr. Padma, can you handle some questions on the chat box? Some questions for you. Okay. Going to the next presentation. Dr. Praveen Kumar Chinna, he has done the fellowship in musculoskeletal radiology and presently the assistant professor in Christian Medical College, Vellore. Very dynamic personality, new youngster in our MSS India. So his area of interest is musculoskeletal radiology and emergency and trauma radiology. So Dr. Praveen, over to you. I am making you the presenter. Okay, let me see, where are you? Okay, fine. So here are you. Yeah. So I have make you the presenter. Now you can share your slides and go on.
Thank you, sir. Thank you for the kind introduction, sir. So is my screen visible now, sir?
Not yet. Praveen, please go ahead. Yeah, we can see it now.
Yes, sir. Yes, sir. Thank you, sir. Am I audible, sir?
Yeah, you are very audible. But the
Thank you, sir.
presentation isn't on. Okay, we've got on. We've got it on. Please go ahead.
Sure, sir. Good morning and good afternoon to everyone. And I would like to first thank all of you for joining us on this Sunday. And I would like to thank MSS India Society and Australasian Musculoskeletal Imaging Group and CMC Velo for this opportunity. So this talk is based on the topic will be imaging guided interventions in arthritis. This is something most of us will be doing everything. I will just touch up the basics and some of the tips and tricks which I've learned from my teachers. And the first part will be, why should we really go about this procedures? Is there really a need for this image guided intervention in arthritis? So also at this point, I would like to thank all my previous speakers, Dr. Emily ma'am, Dr. Josita ma'am, and Dr. Padma ma'am, for beautifully explaining us the intricacies of the arthritis pathogenesis and the imaging appearances. And what we can see in all their talks is, there is one thing that not all the cases are very clear cut. There might be some clinical dilemma. There might be some imaging subtle variations which are not very typical to for whatever etiology we consider. So in such cases, there is a missing link. We will be needing a pathological diagnosis to exclude or to rule out some pathologies. So that is when the role of this intervention comes. Either it will be in the form of aspiration of the joint or biopsy of the synovium, or it is some injection, for example, in a suspected paralabral tear or some other pathology, to ascertain the cause of the pain, to label that this joint is the culprit of the pain or this is the source of pain. We might need to inject some anesthetics into the joint. So these are all the basic important reasons that makes us to do these procedures. First, even though the classical teaching is, if single joint is involved, either we are dealing with infection or intrinsic synovial pathologies like PVNS or synovial osteochondromatosis. But often we do see multifocal septic arthritis or infective arthritis, and often we see unilateral inflammatory arthritis. Those are the cases with diagnostic dilemma where this joint aspiration and synovial biopsy is going to help us. So this is about the reason for the procedure. Let's go about how we, let's move on to the next part, that is how we do the procedure. Before going into the intricacies, I would like to brush up the basics quickly. It's always good to go back to our basics. And it is an interesting fact that we do have around 350 joints in our body. Some of the joints are meant to move, like the synovial joints. Some of the joints are not meant to move, that is the calvarial sutures. And also we have some joints like SI joint where the movement is very little. That's what we call as amphiarthrosis. For today's session, we were from the beginning we were talking about the synovial joints. This is just a repetition of the previous anatomic basics. Any synovial joint will have an articular cartilage, which is the hyaline cartilage. This joint, this alignment is secured by the fibrous tissue, which we call it capsule, that gets thickened at some points of maximum pressure. That is what we call as the ligament, to provide stability. And inside the ligament and the capsule, we have this glistening lining of synovial membrane that secretes the synovial fluid to nourish this cartilage. This, if we take the capsule as the wall, the synovial membrane is something like the wallpaper or the paint of the wall. Now, why this understanding is important is, we can see this part of the joint that is covered by the capsule is devoid of periosteum, and this is the part that's lined by cartilage, and this is the bare area which gets affected by this arthritis. There are a particular form of arthritis which predominantly present as synovial thickening, for example, infections or intrinsic synovial pathologies, or autoinflammatory, that is the rheumatoid arthritis. And there are some autoinflammatory arthritis, that's what we were discussing, in the form of spondyloarthritis. The nomenclature has been changed. Now we put it as everything under an umbrella term called spondyloarthritis, which predominantly affect these enthesial sites. Now, in order to move this joint, we need the help of muscles and tendons, and the tendons also attach at enthesial sites. And these joints, the fluid in the joint will get accumulated little outside the joint line, which also in turn will be lined by the capsule. This is what we call as recess. And between the synovial lining and the capsule, we might get some fat pad, which is intracapsular extrasynovial fat tissue. Like for example, this we often see it in the posterolateral recess of the elbow joint, which is what in radiograph we see as the posterior fat pad elevation in cases of this intra-articular fractures. Also, we have similar fluid, synovial line fluid filled areas, which is called as bursa. The interesting fact is all the bursae are extra-articular. Normally, they do not communicate with the joint cavity. These bursae are present at the level of where maximum friction is there, especially between bone and the tendon, or between bone and the muscles. This is the basic anatomy. The understanding of this recess and bursa helps us in identifying pathologies, especially in fluoroscopy. Okay, so now in interventions, either fluoroscope or ultrasound guided, our target is to go traverse through the skin, subcutaneous tissue, fascia, muscles to enter into the capsule or the joint cavity or the recess. At the same time, we will be avoiding all the neurovascular bundles and the tendons in the course, and also we would not touch the labrum or cartilage. So here are some examples of this synovial, large synovial joints. We do see here, this is the shoulder joint. This is the articular cartilage lining the articular surface of the humerus and the glenoid. We can see the labrum here. This is the capsule and the ligament with the inner lining of the synovium. And the similar thing we can see in the hip joint and also in the elbow joints. These three joints have one unique feature, that is, there are area of these bones covered by the capsule which is not lined by this articular cartilage. That is what we call as bare area. For example, here we can see the neck of the femur, which is intracapsular, intrasynovial. At the same time, it is not lined by any articular cartilage. So these are the areas where we can safely land our needles. And the similar area we can see in the elbow also. In the subsequent slides, we'll be seeing that. Okay, so as we go about the procedure, the most important part will be the planning. That is the pre-procedure part. We must take the history, and it will be important. It will be nice if the doctor who is going to do the procedure screens the patient before the procedure, while even giving the scheduling of the procedure date. And we have to explain the procedure to the patient, allergy check and inform consent. Especially, we have to inform the patient about the possibility of pain or soreness during the procedure, after the procedure, or there is a possibility, especially when we give corticosteroids, there is a possibility of infection, or in case of inadvertent injection of the steroids into the tendons, there is a possibility of tendon rupture. These things must be conveyed to the patient. And the second most important thing is both the patient and the operating doctor must be in a comfortable position. We will be seeing that with respect to each and every joints. And obviously there must be a very clean system, and the sterile tray setting should be in a well organized way, and skin cleaning and draping so that the sterility will be maintained. And next, as far as the procedure is concerned, we can do it either ultrasound, fluoroscopy, or CT guided. Finally, with little observation, we can discharge the patient. This is how the tray must be organized so that we can save a lot of time and save confusions, and we can go about the procedure effortlessly. And regarding the antisepsis, we will first use povidone iodine based solution. Then we can use the chlorhexidine to bring about the sterility. And the most important, as we go to the procedure, the most challenging aspects of ultrasound guidance is needle navigation and positioning and anatomy of the joints. Let's first see about the needle navigation, then we move on to the positioning part. We all know this is one of the famous images where there are two methods to approach a joint cavity. This is the linear probe. Most of the joints are approximately 1.5 to 6.5 centimeter deep from the skin surface. So we don't need a curvilinear probe unless the patient is heavy built. We will be using the linear probe only. And there are two ways we can enter the joint cavity with ultrasound assistance. One is when we place the needle along the short part of the probe, that is along the needle course will be along parallel to the ultrasound beam. That is what we call as in plane or lateral approach. The other way is coaxial or the out of plane approach, where we will be going to the long side of the probe. This is technically less demanding. This is technically very demanding. There must be some expertise in the operator. Then only then we can go about with this procedure successfully. And also this out of plane approach is mostly used when there is anatomical restrictions. There is very less space for us to navigate through, especially in the joints of small joints of hand and foot. So this is just a schematic to show in plane when the needle courses along the ultrasound beam. It is always good to have the beveled edge of the needle facing towards the skin surface, so that we can see the reverberation artifact cast down by the needle in a very good way. Needles are a very good specular reflectors, and this is how we are trying to reach into the joint cavity. Let's see, this is when the needle is having a in plane or a course which is along the ultrasound beam. What if the course is tilted? This is just a craniocaudal view, or just assume that we are viewing from above. This is the probe footprint, where the operator is passing the needle, but here the needle assumes an oblique course. If that is the case, then the beveled edge of the needle will not be nicely reflected upon the ultrasound screen, and also we won't be getting this nice reverberation artifact. As I said, these needles are excellent reflectors. We don't need any extra special items attached to the needle to increase the reflection. When the needle course is approximately 90 degrees to the ultrasound beam, the reflection is the most, and we can get nice reverberation artifact like this. So here we can see the needle is passed. The entire course of the needle is seen in this image. We should never advance the needle into the body if we don't see the tip. We should always see the tip. The thing is, this ultrasound guided interventions are not a test of our speed. It is a test of our competency. It's not how fast we do, how safely we do. So what we should do is, when we pass the needle, starting from the beginning, from the skin entry point till the area where we're intended to land the needle, we should be able to see the needle tip. And when we do, the reflection will be very nicely. This reverberation artifact, the ringtone artifact, we can see very nicely. Not only in this static image, even when we do, this is a case of a dry needling we did. Here, even when the needle is moved, we can see the plane of the needle is maintained along with the ultrasound beam. So we can see the reflection very nicely in this case. Also, if we are not able to see the needle, we will not do any harm to the patient if we don't move the needle when the tip is not seen. We should always make sure that the needle tip is seen and slowly advance it with this approach in our mind. Both the needle course and the probe insertion angle must be parallel to each other. Okay. So this is regarding the first part of the needle navigation, and these are some good examples of how not to do. We can see here there are the reverberation artifact is not good, and in this case of synovial biopsy from an elbow joint, we can see too much of air has been gone because the stellate was not placed between the sampling, and here we can see the needle is not nicely seen, and in such cases we can get benefited by little heel to toe maneuvering of the probe, and we can see the beveled edge of the needle nicely here facing towards the skin surface. So this is regarding the needle position, and let's come to the probe selection also. This one, all the three are examples of hip joint. This is in these images we can see we have used the very high resolution probe, that is that 18 megahertz, and when we use 12 megahertz, we can use this in heavy build patients, especially in hip joints where the depth will be approximately here 4 centimeter. Sometimes it can be 6 centimeter, as in this case. And we will not be, as we use the spinal needle into the anterior recess, we are not able to see the needle very well, as we have seen in the previous cases. And here, though we have used the 12 megahertz frequency probe, we are not able to see this. In such cases, what we can do, we can use the curvilinear probe. So one more point about the needle navigation. When we do the procedure, finally we are reaching into the joint cavity. The beveled edge, the tip of the needle, can touch the articular cartilage, but we are not supposed to poke into it. And if we poke into it and if we try to manipulate it, we might even cause fissuring of the articular cartilage. In such cases, how to go about it? I am at this point, if I want to navigate to the other part of the joint, this maneuvering will be helpful to us, especially when we are doing the procedures in small joints of the hand and foot. And what we can do is we can rotate the needle and we can keep the slant aspect of the beveled edge of the needle along the convexity of the cartilage, and we can slowly glide it over it and reach the other part. As I said, this will be very helpful when we do aspiration or when we do injection of the small joints of foot and hand. Okay, so here we can see the two ways. This is the shoulder joint through the skin deltoid. The needle by the lateral approach has entered into the joint cavity. This is the rotator interval where we are seeing the beveled edge touching the articular cartilage at the humeral head. Whereas here this is lateral approach that has been done in a case of hip joint, where we can see the beveled edges conforming to the convexity. In such cases, we can easily navigate through the joint space without even damaging this articular cartilage. Okay, now we have finished about the one of the toughest things, that is the needle navigation. Let's move on to the second most important thing, that's the positioning of both the patient and where to target the anatomical aspects of this aspirations. Regarding the modality, ultrasound has the real-time exact visualization of the needle tip, which is not feasible with fluoroscopy. But still, fluoroscopy is preferred for arthrograms because we can see the contrast filling up the joint cavity, and also it is overfilling and exceeding into the recesses. And sometimes if there is pathological communication into the bursa, we can see even the bursa getting distended in fluoroscopy, which is not always possible in case of ultrasound. But the advantage in ultrasound is we can even do the biopsies along with this kind of intervention aspirations. So let's go joint by joint. I'll just go through the fastly about the anatomy, then we will see the practical cases. In the shoulder joint, we can approach this joint cavity from posteriorly or from anteriorly. Anteriorly, this is the rotator interval. That will be the area we will be preferably entering. Just close to the superior border of this subscapularis, we can pass the needle and we can enter into the joint cavity. Posteriorly, we have one important area called the bare area. This is that articular cartilage lining the humeral head, and we can see the trifaceted greater tuberosity. This is the middle facet and this is the inferior facet, where in the middle facet is going to be the footprint of the infraspinatus. Just medial to that, we will see some pitted, even in normal patients, sometimes we can see some pseudo-erosion-like appearance. That is what the bare area is. When we approach from posteriorly, we can safely land at this place, which is also intracapsular and intrasynovial, or we can even go into the joint cavity as we see in the subsequent examples. Finally, what we see here is the friction between the rotator cuff and the acromion is prevented by this beautiful structure, that is the SASD bursa, which in turn lined by this deltoid muscle. That is how we are going to navigate, traverse all these structures to reach this point. Here, this patient has been positioned in prone, and it is preferable we can ask the patient to turn the face to other side. And what we are trying to do here is we are trying to enter the shoulder joint from posterior approach. Here we are trying to do the in-plane or the lateral approach. As we enter, we are going from medial to lateral aspect. Here we can see this schematics showing the articular cartilage line humerus, and this is the labrum, and this is the infraspinatus through which we are going to enter into the joint cavity. And here in the ultrasound, we can see the skin, subcutaneous tissue, fascia, the deltoid muscle. This is the infraspinatus, and we can see the bony glenoid margin and this echogenic labrum. And we are not supposed to poke the labrum, so we are pointing the needle as much as away from the labral tissue. Or we can even go and reach in a inferior position, we can go and reach into the bare area level, where there is no fear of poking the articular cartilage at all. Okay, this is about the posterior approach. Shoulder can be accessed anteriorly also. In this, we have to ask the patient to keep the arm by side and the palm facing upwards. This is important in order to avoid the tension over the anterior capsule of the shoulder joint. And we keep the probe in an axial orientation, where we can see this echogenic coracoid process, and this will be the upper aspect of the subscapularis tendon. And here is the obliquely oriented biceps and the rotator interval. Here we can see the coaxial or the out of plane approach of the needle. The tip is seen close to the subscapularis, and this is the deltoid and the subcutaneous tissue. This is also another way of approaching the shoulder joint. So commonly we use 18 gauge needle for aspiration and 20 to 22 gauge needles for other injections and all. This is the example we have already seen, the anterior in the lateral approach. Now moving on to the elbow joint, regarding the anatomical features of the elbow joint, this is the posterior and lateral view. This is the capsule that is securing the elbow joint. What we can see here is medially we have the ulnar neurovascular bundle, anteriorly we have the brachial vessels and the median nerve, and the anterior recess of the elbow joint is very small, where here we can see below the brachialis here. We do have two areas to access into the elbow joint. One is the posterolateral recess approach, another one is lateral approach. This is the part where the radial head and neck junction is there. This part is a bare area where we can safely land our needle tip without even worrying about injuring the articular cartilage. So this first one is the example of posterolateral approach. Here we can see this is called the elbow is flexed, and this is the crawling crab position, and the forearm is a little pronated so that we can easily access this posterolateral recess of this elbow joint. Here we can see the olecranon fossa. This will be the triceps muscle, the capsule, and this is the extra synovial but intracapsular posterior fat pad. And we can see this distended joint cavity and the needle tip at that olecranon fossa here. This is the posterolateral approach. And regarding the lateral approach, here once again we can keep arm by the side of the patient. Here we can ask the patient to sit, and over the table in a semi-pronated way we can keep the arm. And here we can see this is the common extensor tendon we see here, and this is the lateral collateral ligaments. We are just coursing through that and reaching the bare area of the elbow joint in the lateral recess approach. This is another view where we are using this out of plane or the coaxial approach to enter into the radiocapitellar joint space. Here we can see the echogenic needle tip, and this is the common extensor tendon that has been crossed. Okay, that's about the elbow. Now moving on to the wrist. Wrist, we know it's an area of multiple joints which normally do not communicate with each other, though it looks like a single joint. We have this distal radioulnar joint, which is proximally sealed off by its capsule and distally sealed off by the TFCC complex. And we do have here the next compartment distally is the radiocarpal joint, which is also sealed away from the midcarpal joint by this strong interosseous ligaments, scapholunate and the lunotracheotrals. And these carpo-metacarpal joints may or may not communicate with this midcarpal joints. So for wrist interventions, what do we prefer is the dorsal approach, because the volar approach is the volar anatomy is too crowded. We have all the complex neurovascular bundles, and also we have the tightly packed flexor tendons, which won't give us enough space to navigate the needle. So we can safely navigate the needle to the dorsal approach. What we can do, the patient can sit and keep the arm over the table in a pronated way, and we can keep a small pad underneath the wrist so that we can open up the dorsal joint space here, and the needle can be laterally passed in the lateral approach to reach this articular synovial cavity. This is for the radiocarpal joint. Now, this is for the distal radioulnar joint. We can see here, this is the thenar aspect and this is the hypothenar aspect. The needle is being advanced from the radial side to the ulnar side of the DRUJ joint here. And as we do, what we can do, we can even place one small pad down this hypothenar eminence in order to take away this wrist obliquity and to easily facilitate the passage of this needle. And here we can see the bevel edge is facing down, and this is the joint cavity of the distal radioulnar joint. And this is about the midcarpal joint. We can approach either through this lateral or in-plane approach, or through this out-of-plane approach, as we see here between the lunate and the capitate. And this is, we can see excellent synovial proliferation is there, which can be even biopsy can be done from that place. And this is about the first carpo-metacarpal joint, the trapezio-metacarpal joint, where we can again use this kind of coaxial approach, where we can see the needle tip here, and this is the distended synovium. And we can also use this lateral approach, where we can see the needle entering from this proximal to distal manner. This is finally about this small joints of the hand, where we can once again ask the patient to keep the palm facing downwards, and dorsally we won't have the fear of injuring the neurovascular bundles or the big tendons, we can use this out of plane approach because there is limited availability of space here. We can see the needle tip between this phalanges. Now moving on to the hip joint, as we know, the largest ball and socket joint of the body, this hip joint is reinforced by some of the strongest ligaments in the body. Anteriorly is the iliofemoral, which is the strongest ligament, and we have that ischiofemoral and pubofemoral ligaments, and that is what we are going to traverse to enter into the anterior recess of the hip joint, which is the only easily approachable recess of the hip joint, which is also the more capacious one. And what do we have to keep in our mind is, here we can see in this schematics where they have ripped off the ischiofemoral ligament to show the synovium, which is lining the bare area of the hip. And this is the area we are going to enter. And we have to be careful. In some patients, this is the profunda femoris artery where we can, that is giving off the medial circumflex and the lateral circumflex vessels, which will complete the anastomosis around the hip joint. While we are inserting the needle to reach this bare area, in some patients, the needle might have, the vessels might have a very close course to the trajectory of the needle. We should be very careful regarding that. Usually the vessels will come at this place. Here we can see the needle that is placed at the anterior recess by the lateral approach, and here we can see the needle that is placed at the femoral head where the articular cartilage is there with a beveled edge down. So this, while doing this procedure, we must ask the patient to internally rotate the limb a little so that the tension over the anterior capsule of the hip joint will be relieved. And this is again, we already saw this. Here we try to insert the needle at the level of the femoral head, little inferiorly, so that we can see the needle in a 90-degree plane to the ultrasound beam with good reflection here. This is also a way to enter the hip joint. In such cases where the circumflex vessels are very close to the needle trajectory, this is the cordocranial approach we do here. In some cases, we can even try craniocaudal approach by passing the needle from the other side to the anterior recess. That will be especially helpful when we are trying to do ultrasound guided biopsy of this anterior recess when it's nicely distended with synovitis. So now finally moving on to the knee joint. In the knee joint, we can see from the schematic that medially we have this bulky vastus medialis, whereas laterally the vastus lateralis already finished and we see just a few reinforcing fibers of vastus intermedius and the lateralis at this area. And this is mainly guarded by this patellar retinaculum. And this is here the ligament and capsule has been ripped off, and we can see this glistening synovial lining. This is the knee joint, which extends a suprapatellar recess here, and the suprapatellar recess has the medial and lateral parapatellar gutters. And also we can see physiological extensions as here the popliteal recess in this side. So what usually we try to attempt is bilateral to medial. We prefer lateral to medial because there is not much of muscle bulk in the lateral aspect, and that will be very comfortable for the patient also relatively when we compare it with the medial route. And we will try to enter into the suprapatellar recess. Also, we can do from laterally, if the effusion is not much, we can enter into the parapatellar gutters as well. So here we can see this in-plane approach. We can see here the needle is being traversed from proximal to the distal way, that's cranial to the caudal approach, reaching the suprapatellar recess. When there is enough amount of synovitis, we can even do biopsy from this place. So finally, this is the ankle joint. Regarding the ankle joint, we know the tibiotalar articulation. The tibiotalar articulation has three important recesses, of which only two are easily accessible. One is the anteromedial recess, another one is anterolateral recess. The another recess is the posterior recess. The functional importance of the posterior recess is posterior recess may communicate with the posterior subtalar joint as shown in this schematic. And this is the view from anterior aspect. The talotibial joint is completely sealed off from other joints here by this tight capsular reflections. Whereas posteriorly, the ankle joint can, via the posterior recess of the ankle joint, can enter into the posterior subtalar joint recess, which in turn even communicate with the flexor hallucis longus tendon sheath also. And also they may communicate into the sinus tarsi, especially in pathological states. So as I said, the easiest approach is to do either anterolateral or anteromedial. Anterolateral is preferred because we can avoid dorsalis pedis in this side. And only thing to keep in our mind when we go about anterolateral recess approaches, just anterior to the lateral malleolus, we have this superficial peroneal nerve bifurcating into its terminal branches, that is the medial and intermediate dorsal sensory nerves. We can take a little care not to injure those nerves, especially when it is seen in high resolution ultrasounds. So that way we can do either this kind of a lateral approach. Here we can see the needle tip that is reaching up to the anterior recess of this ankle joint. Yes, and in cases where of subtalar involvement, when we try to take aspirates or inject into the subtalar joint, here we can see the calcaneum and the talus. This is just a simulated image of needle tip at this area. We can see by using this is a small footprint probe, where we can see by coaxial method we can reach the area of that posterior subtalar joint from the lateral aspect very safely. So this is about the pre-procedure and procedure. And post-procedure, we must observe the patients for 30 minutes to look for some complications. We will talk about it little later. And especially in case of corticosteroid injection, we must advise the patient not to do rigorous activities. When it is upper limb interventions, we should advise them not to do heavy weight carrying and all. And for pain relief, we can give oral NSAIDs or little ice packs at the local site also will be of lot of help. Now, some tips about these things which I've learned from my seniors. And one thing is firstly about the safety. We might be having a very busy center, and of course that is how most of the MSK centers are working. Often we won't get enough time to talk to the patients, and there might be a lot of anxiety, a lot of concerns which goes unaddressed. And this is a very nice article that I happened to read. There they say, how can we improve? There is always scope for improvement in the services we cater to our patients. There they give wonderful ideas to improve the patient experience over this whenever they undergo this MSK intervention procedures. Most of the time we do that to relieve the pain. Also, the experience not only involves that starts from the point where the patient enters the department, where the scheduling of the procedure happens, and from the beginning to the post-procedure area, the patient must be given a platform so that they can easily come up with the discussion, or they can let us know about their concerns either through phone calls or by on-call system. And the informed consent process, as I said, must be also done detail regarding this during procedure, post-procedure pain and soreness. And also in some patients, we might end up having steroid flare. That is, after injection of steroid, there can be increase in the inflammatory activity or in the pain perceived by the patient for 2 days, that can be easily treated with this NSAIDs. That also has to be conveyed to the patient. And these are very nice principles which we can easily practice in our day-to-day practice, just being by observant, and also being by using encouraging and psychologically impartial language, we can alleviate a lot of concerns and apprehensions in patients. That's about the safety. Then often something we talk very less about is the syncope. This is also a recent article by Dr. Bochu said, and here we can see the vasovagal response. It's not very uncommon. Actually speaking, it can have very subtle manifestation like just a dizziness, or it can even end up at asystole, especially when we deal with athletes. When we deal with athletes who tend to have this high vagal output intrinsically, naturally, and when they are in a dehydrated state, they are prone to have this vasovagal attack. And this can be so bad that the patient even can fall from the table during the procedure, or just after the procedure. If the patient gets up abruptly and he starts walking, here if they start walking, they might even fall down. That will cause more harm to the patient. So those things has to be kept in mind, especially when a patient is very anxious. We should be like very proactive in looking for this onset of this vasovagal reactions or something. This can be easily avoided by having well hydration. And also we can, when it happens, we can immediately do the Trendelenburg position with the legs elevation. And also when we keep some cold cloth over the neck or forehead, we can try to revert these things back very soon. Next, about this concerns of the pharmacological agents, mainly the local anesthetics. Especially commonly we use 3 drugs. One is the lignocaine, bupivacaine, and the ropivacaine. The problem with lignocaine is known to have of all the local anesthetics, lignocaine is known to have this chondrotoxicity, and also it is noted that lignocaine has bacteriostatic and bactericidal effects. This is very important when we are going to do a joint aspiration in order to prove or disprove an infective arthritis. In such cases, we are not supposed to inject the local anesthetic into the capsule. We might take it till the pericapsular area, but we should not inject it into the joint cavity so that it will alter the test results. Of all the three, the chondrotoxicity is more seen in lignocaine and it is least seen in ropivacaine. But the problem with ropivacaine is it's very costly. But in such cases, if the patients are not affordable, we can even go with low-dose bupivacaine. Finally, about the steroids, we all know steroids are double-edged swords, and this is the concentration we will be using for small joints, intermediate, and for large joints. And the steroids they come in two forms. One is the particulate, that is the methylprednisolone, betamethasone, triamcinolone, and soluble form dexamethasone. The soluble form only the soluble form should be used whenever we are doing any procedure near the foramen, spinal neural foramen, because there is a risk of embolization with this particulate material. If we use that, it may even cause infarctions. And also, when we use dexamethasone, we should be careful. We shouldn't mix dexamethasone and ropivacaine, because once again, that will not serve the purpose. The ropivacaine will cause crystallization of the dexa, that combination, and this still we have this risk of embolization and infarction. And also, how often can we do? We can give a 3 dose per year with at least 4 to 6 weeks in between 2 injections of the steroid. And we are not supposed to inject steroids in medication. If there is a cellulitis and the procedure has to be done, we can try to choose either other alternate path that will avoid this path of cellulitis. And it is better to avoid steroids just 3 months before any knee joint replacement surgery or something, especially in patients with osteoarthritis. This is the conclusion. First, we saw the reasons. Often in our day-to-day life, we don't have very straightforward cases. So only the ultrasound guided either aspiration or injection is going to help us in reaching at a proper diagnosis. And also, the most important and challenging aspects of this procedure is needle navigation and understanding of this intricate anatomies. And finally, we saw about some drug toxicity and important things of how to improve the experience of patients while they undergo this MSK procedures. And these are my references. I thank you so much for your kind attention. I would like to thank again MSS-AMSIG and my mentors and teachers, Dr. Madhavi ma'am, Dr. Pushpa ma'am, and a special thanks to Dr. D.K. Singh sir for this opportunity. Thank you so much.
Thank you, Dr. Praveen. That was excellent. And I think you've done justice to what all that you do in this wonderful institution, CMC. It's a very hoary institution in the south of India, doing extensive and very detailed work. And your talk has just showed us that. Thank you, Dr. Praveen, for a lovely talk.
Thank you, sir.
And I wish all the attendees have benefited from this wonderful webinar of both our societies. And so over to Dr. Dharmendra for further progression of this session. Please.
Okay, thank you, sir. Yeah, thank you, sir. Dr. Praveen, very nice talk. You have very rich content and, practical approaches. And particularly, I want to mention you have a very beautiful background slides. Like,
thank you, sir.
Means you are doing the intervention in the midst of nature. So that feels good. Okay. And thank you, Jairaj, sir. So we are at the end of this session. Okay. And before we conclude the session by Dr. Emily, vote of thanks. Okay, I would like to play the message from the President MSIG, Dr. Tim Dixon. I'm sorry, I should have to play this in the beginning, but let me see.
And we do apologize for the fact that we couldn't do it in the beginning. So yeah, kindly bear with us and kindly listen to
in Melbourne, Victoria, and I have the pleasure of introducing the AMSIG portion of this meeting today. Today is the second Joint Society online CME webinar between MSS and AMSIG, following on from their successful meeting last year in tumour imaging. Today we move on to arthritis, and we have two upcoming stars of AMSIG to speak for you today. The first of which is Dr. Emily Davidson. Emily is a musculoskeletal radiologist from Sydney, New South Wales, Australia, and is the current AMSIG secretary. She completed her radiology training at Royal Prince Alfred Hospital in Sydney, Australia, and her MRI musculoskeletal radiology fellowship followed on in New York at the Hospital for Special Surgery. During her time at HSS, Emily was awarded the Charles Christian Award for Excellence in MSK Research and the Robert Freiberger Fellowship Research Award. Emily has been a previous co-convener of the AMSIG Scientific Conference in 2021 and was also a representative on the AMSIG Education Subcommittee. She currently works in public and private practice in Sydney, Australia. Her public commitments are at the Royal Prince Alfred Hospital, where she specialises in MSK imaging, in particular tumour and rheumatology imaging. She also works in private practice in Castlereagh Imaging in Sydney, Australia. Her talk today will be on imaging and inflammatory arthritis, what a radiologist needs to know. She achieved membership of RANSCA in 2021 and then pursued an MSK imaging fellowship at Perth Radiological Clinic. She now works for Perth Radiological Clinic in Breast Green, Western Australia. Padma's talk today will be post-treatment imaging in arthritis, what a radiologist needs to report. I'm sure both talks today will be of excellent quality, in addition to the two MSS talks provided by the Indian speakers. I'm currently in Fiji with my family, so I must admit I'm currently not online, and I pre-recorded this message in case the internet was suboptimal. I'm sure all talks will be excellent, and I look forward to catching up on them on my return. AMSIG's collaboration with MSS, although only in its second year and relative infancy, is one of our strongest inter-society relationships, and I'm pleased to see that this is progressing nicely. I'd like to thank Dr. Chowdhury, Dr. Govindaraj and Dr. Singh for their collaboration and efforts in making this second webinar happen, and I look forward to this being an ongoing annual event. Also, I'd like to see increased inter-society relations with both our societies, whether it be our annual scientific meetings or other online webinars. For those who are interested, we will be holding our annual scientific meeting in sunny Noosa on the Sunshine Coast of Queensland on the first weekend of May of this year. For those able to come out, we would love to see you. And if not, there is an online live access feed to the meeting. I trust you all enjoyed today's second webinar, Crossing Borders with Arthritis, and look forward to seeing you online or in person in the near future. Take care.
That was the message or recorded message from Dr. Tim Dixon. So should we proceed further? And may I request Dr. Emily Davidson, the current secretary of AMSIG, to conclude by the vote of thanks message.
Thanks for that. Yeah, it would have been good to have Tim talk to us at the first, but I understand with difficulties with the technology. But just wanted to re-emphasize what a fantastic session that we've had today, talking about updates of arthritis, whether it be inflammatory arthritides as well as infection, and with updates on how to do image-guided interventions. So in my talk, I focused more on sort of the initial diagnoses and imaging, and mainly focused using radiography and how ultrasound or MR can be used to have in more challenging cases. And then we heard from fantastic talk from Dr. Joshita Singh, who gave us an update on infection and the sort of background of how infection gets into the joint and the clinical features and how it corresponds to the radiological findings. And And then we heard from Dr. Padma Menon, who carried on from my talk, giving us an update on the literature of post-treatment imaging, as well as how we can guide imaging for whether patients are responding well to treatment and looking for signs of a progression. She gave us a great overview of the current literature, and as well as a few updates in new imaging techniques, such as with the PET imaging, which was quite interesting. And then lastly, we heard from Dr. Paveen Chinai, who gave us a quite comprehensive overview of how to access joints when you're needing to do interventions or procedures on these patients with inflammatory arthropathies. And I just wanted to highlight there that we perform most of our procedures supine because we do get a lot of patients that faint regularly. So it was interesting to hear you say that about your cases. So it's a universal thing that patients get vasovagal. So yeah, just to kind of emphasize again, it's a great opportunity for our two societies to collaborate together and share information and share our expertise and our knowledge. We have, you know, a large amount of experience amongst our members, and I think ongoing inter-society collaboration will only continue to further our learning and education, and as well as our professional friendships across the ocean. So I'll hand back over to Dr. DK, or is Dr. Singh?
Okay, thanks, Emily, for the nice vote of thanks. Okay, so now I'm concluding this session by speaking few words that we in India call few words, but we give long lectures, but I'm really speaking few words. Hello everyone. As Secretary General of MSS India, I would really appreciate for the successful culmination of this remarkable online event. First and foremost, I extend my deepest gratitude to our distinguished speakers whose expertise, insights, and passion have enriched our understanding and inspired us all. Your dedication to advancing musculoskeletal imaging is truly commendable, and we are immensely grateful for the knowledge you have shared with us. And a special word of thanks goes to our attendees, whose active participation has contributed to the vibrancy of this gathering. Your enthusiasm has been the driving force behind the success of this event. Last but certainly not the least, I extend my gratitude to Dr. Tim Dixon, the President MSIG, and Dr. Gerard Govindraj sir, the President MSS India, whose expertise and support have enabled us to come together virtually across the globe, and that's the theme of that a theme of our session, crossing the borders. As we reflect on the wealth of knowledge exchanged, connections forged, and insights gained during this meeting, let us carry forward the spirit of collaboration, innovation, and excellence in our continued endeavors to advance musculoskeletal imaging. Thank you once again to everyone who has played a part in making this event a resounding success. May the insights gained here today serve as a catalyst for future discoveries and advancements in our field. My warm regards to all. Thank you. Thank you so much.
Thank you, one and all. Thank you.
Thank you. So I am now continuing. I'm leaving the session. I'm stopping the session, and thank you once again all. Thank you. Thank you so much.